We could see your background change, Chris. Euro Anesthesia 2020. We can't hear you, Chris. We can't hear you.
Yes. Now it's good.
My next lecture at 5 o'clock.
Okay.
So you got things already set. With a click of a button, the background will change.
Click away, always. Good advice is a click away, so that's always like that. So,
right, guys. So you know, at one point as well, I will have to. We can't hear you, Chris. We can't hear you.
Now it's good.
You know, I will be leaving
my next lecture.
Point, so do excuse me if you know, but I will be able to watch the rest of the meeting on the Facebook and YouTube. So that's cool.
Yeah.
Okay. Thank you so much. Great.
And anyway.
Fantastic. All right.
Yes.
Brilliant. Okay. So, Ahmed, whenever you want to start.
Yes.
Okay.
Well, yes, I will resend just the link to Amitabh.
Okay.
Just 1 minute, please.
Oh.
Amit, good to see you.
Hi, Amit.
Hello, everyone. Sorry.
Good to see you.
Good to see all of you. I got my times crossed, so I'm on.
Yes.
I thought so, because that's what I was telling Amin, that, you know, it's like 10:30 New York time. Not sure whether actually, you know, what time happens, you know, in terms of winter. So
yeah, so it's 9:30 here, so I'm off by an hour.
Okay.
So I ran here, so that's why I don't have a suit on.
Okay.
I was like, oh.
Anyway, you're here, so that's great. Fantastic.
Good.
Yes. I don't know if it will be the same for others, because
yeah, I don't know. I guess I don't know that. I think the email, it says 10:30 for me.
Oh, okay. We'll send them an email for that, but I don't know. We can start if you want.
Hello, Anne. How are you? Yeah, you think it's I think we have, yeah, we might as well start, right? We have Anne, and then I guess we have Carolina. I don't know if she's not on yet.
No.
Do I see her? I'll WhatsApp her and see.
I mean, if you want, I can say now some words, because when we are now...
yeah, let's go ahead and say words. I'll text her afterwards.
Yeah, because...
yeah, let's start.
Jump over to the, as you can see, to the faculty meeting of the lecturer at Euro Anesthesia digitally.
Okay.
Amit, as I said to you, but But my strong congratulations to all of you for this wonderful meeting in Morocco. And we are flying just in minutes to another side. So I'm really happy to join that world. But you are joining a very important mission, and under the leadership of Amit, I'm very happy that this is happening, because education and training is the most important that all of us do have. Yeah. Secondly, connectivity, so that we know each other, and we are strongly connected all over the world now by the Zoom possibility. So please use that and make your questions by the chat. It's really important that people who want to be helped or want to be trained or want to be educated, that they give their message. And the more, because pain is really a challenging problem for all over the world. So I think that interventional pain practice in these times of opioid crisis in some parts of the world give a very good solution for the future to raise less problems, I think. So referring to a good pain center is important, and I see really a huge amount of attendees now during this meeting. So congratulations to the local organizers for that visibility. And I hope that you, by the next months, will work on case discussions and further education on guidelines. We have beautiful guidelines available, so that your best possible outcome for the whole area of North of Africa is possible, because you are great leaders. So thank you for that. And I really congratulate all the speakers to join this message. Amit, thank you also. Enjoy your afternoon and morning.
Thank you very much, Dr. Chris Visser, for your support and for your presence. And we hope, and I'm thanking you and all the faculty, Dr. Amit, Dr. Anne Lucas, Dr. Sifrian, Dr. Sadek, and all the faculty. I am thanking you for your support for the Moroccan Pain Academy, your support for starting concept pain intervention, concept pain units in North Africa or in Africa. Thank you very much, and thank you for your time and your kindness. Amit, I don't know if we start.
I think we should go ahead and start.
Okay.
I want to echo everyone's comments. Once again, it's wonderful to have all of our colleagues around the world here, and a wonderful opportunity in Morocco to really advance this field and make a difference in their country. And thank you very much for all having us. Everyone is safe at home at the same time. I guess we'll lead lead this for here on out.
Thank you. Welcome to Dr. Sifrian Manuel from Spain. Dr. you want to start with Dr. Anne Lucas, or we start with discussion about starting activities? And I have a question for Dr. I don't know if we can start with the discussion. But I have some question for Dr. Visser and for all the faculty. How can we start without guidelines in Africa and without guidelines in concept pain for starting activity from zero activities? How do we do for this changement and change in mind? And how do we do, for example, for starting the activities without less side effect, less complication for our patients?
Yeah, this is a wonderful and very broad question, of course, but I think that first of all, you have a lot of examples of guidelines all over the world, but you should translate what is in agreement with the possibilities you have in your country. That's first point, I think. Secondly, that WAPMI and a lot of other societies should help you to make a working party to see what guidelines are very useful for you and how you can manage to make a structure, because the structure is the start of everything. So if you have some doctors who are willing to make a pain center, and that people know where that pain center is, and you have that pain center as a training center of the future, I think that would be the first step. And once you have that structure, you go for process, so making these guidelines digested or translated to your local situation. And of course, I think that Amit and a lot of other people will help you with that. And then the third level is that your doctors, your anesthesiologists, and all your people who are working on pain, that they are strongly involved in your mission as a society, in your country. I think that will be the third step, and having these meetings will facilitate that. And I think an advantage of the whole Corona situation is that we have much better and much easier contact with each other by a vertebral way. And I know that most of you want to smell the other one, but having just this contact is wonderful. So make a good plan, and for sure we can help with that plan. I'm working now with days also in Tanzania, for example. We have a hub in South Africa. We are working in Indonesia to start up better pain centers and pain care for the people. And we have wonderful guidelines, wonderful missions, wonderful educational programs for ultrasonography with WAPMU, for more interventional by X-ray, by WIP, by EFIC, and by EASP. So use all these people and bring them together. I think that's the most important you can do in your country.
Okay, thank you. Thank you very much for this precision.
Does anyone else want to give some advice? Anne or Sadiq or Manuel?
I think it's just a comment. I think we have plenty of well-established guidelines now. I think it's just kind of, bringing all the societies, as Dr. Weiser's mentioned, it's bringing everybody together and making the most of those guidelines. And I think training is something that's so important. It's, pain is so common, but there are people who haven't been trained how to assess. And I think gone those days when opiates were dished out. I think that's why we have this problem of crisis. But every pain is different. I mean, cancer pain is different. Myofascial pain is different. Arthritic pain is different. So I think it's teaching and training in the pain medicine is going to be such an important part to take the kind of, to provide the best quality patient care. That's what I think. And that's where we should put more efforts into. And I think, as Dr. Weiser says, bringing all these societies together and providing a good quality training is what we should all work on. So that's what my comment would be. Okay.
One piece of advice I do have, when we had a similar situation, even in the United States, where most of our pain care was done by palliative services when I started working at Sloan Kettering, is that you really want to focus on a few oncologists that really are willing to use you as a service to build an oncologic pain service. So for me, that had to be the thoracic oncology service. They seem to really gravitate towards our intercostal nerve block. And then when we made the pain relief better with, neurolyses, that service began to use us more regularly. So you really want to work with which oncologists in your institution will likely work with you, and then that might be the most helpful in the beginning, because I think when many mistakes, at least made in the United States, is people who are interventional will ask their oncologist, I can place an intrathecal pump. But in reality, from an oncologist perspective, it's who can help me manage the pain. And so you really want to hone in on what the oncologist really needs and offer that to them. And then the intrathecal pump, the neurolytics, all these things come as secondary to the treatment plan. Really, the oncologist wants someone to help with pain. The how is not as important to them as the fact that you can do it.
And help them measuring pain also. I think really important is that, it's a very good point of Amit, that the oncology should be your friend together to the patient. And you have to be very proactively, don't wait for the patient, but go abroad and take contact with the oncologist, with the nurses. I think that your nurses will be very helpful also in that mission. And that the voice of the patient is heard, because there's a lot of publications all showing that patients with cancer do have a lot of pain, and for sure at the end of life. So that mission making possible, and please contact us that we can help with that to measure and to make that contact with the oncologist. Really important. That will be my message also in 1 hour for the European Society of Anesthesiology.
Yeah.
Same story.
I agree perfectly with Chris and Amitabh, and I would that's the most important factor, that creating conscience for the patient that is suffering in all the disciplines involved in cancer treatment, and well, make yourself known, make them find you to deliver any kind of pain therapy. That's also in my opinion the most important thing.
Okay, thank you very much for precision and your recommendation, and it will be good to start our activities, and hope to have you all with us for supporting us for starting and developing this activity in Africa. In the main of this recommendation is collaboration with oncologists, radiotherapists, and the collaboration between anesthesiologists and oncologists and pain medicine doctor. We'll start with training, perhaps training between these 2 or 3 specialties who are in the field of cancer pain medicine, oncology, anesthesiology, physical medicine and rehabilitation, or perhaps neurosurgery, and want to make them together for bringing them in this field, and for saying that there is not just morphine prescription in the field of cancer pain, but there is interventional pain procedures and non-interventional pain procedures. And in the world, there is there is a lot of guidelines and recommendation and innovation in this field of research, and the main of that is to make our patients without pain, and for having a good end of life and supportive care for our patient, without, for example, morphine side effects, or without complication, and without without invasive or non-invasive procedures, inutile procedures. Now I don't know, Amitabh, if we agree, we can start with our lecture. I am thanking our faculties, and I'm very, very grateful and happy to have you in the Moroccan Academy of Pain, and you are welcome, by the way, in Morocco after COVID-19, perhaps, and because in this year we have last year in November last year, we have the first WAPMO meeting in Marrakesh, and we plan to have next year the second WAPMO meeting of North Africa and Iberia, perhaps in Marrakesh or Tangier after COVID. You are all welcome, and hope to discuss after 1 year this field on cancer pain, and hope to discuss how to develop with starting, and how to start this year, this activity, for discussing other developing field in this activity next year. Thank you very much.
Thank you, Amin. So I think it'd be best to start now with Dr. Lucas. who's been a dear friend and colleague who I visited a couple of times in the Netherlands. Now I was in Maastricht, who really actually gave me some advice on helping some of our breast cancer patients many years ago. I don't know if she remembers anymore, which I actually use now. So I thought it'd be very helpful as she started with her ideas and treatments for post-mastectomy pain, which I feel on a personal level is one of the patient populations in oncology that has been under-addressed, meaning we have not taken good care of these patients for many various reasons. And hopefully we can take some of these ideas that Dr. Lucas provides so we can provide a little bit better care for this patient population, which I think has been underserved in many parts of the world. I guess you'll share your screen if you can, and then thank you very much. You'll have to come off muting.
Unmute now again. Yes. And yes. So can you hear me? No?
Yes.
Okay,
That's very good.
great. All right. Well, thank you, Amitabh, again for inviting me to present and share my experiences in treating patients with post-mastectomy pain syndrome. Maybe a short introduction of myself. I am an anesthesiologist and pain specialist, and I've been working in cancer pain care for about 15 years now. And the last 10 years, I really focused on the treatment of patients with breast cancer and also with survivorship complaints. As I understood, there is the audience consists of pain specialists, but also of oncologists, and maybe this is a first step to gain more conscience for the pain problems we have with breast cancer patients or the survivors of breast cancer. The prevalence of pain complaints after breast cancer treatment is about 40%, meaning that a big percentage of patients suffers from pain. And I always show this table because to me it's very impressive that within years of less and less invasive surgery, the prevalence of this pain complaint hasn't decreased. In the contrary, it seems to increase. Next slide. So what is post-mastectomy pain? Well, the original syndrome is defined as a neuropathic pain syndrome by the IASP. Pain is mostly continuous pain localized in the axilla and the ventrolateral thoracic wall and the medial forearm. And this more continuous aching pain is exacerbated by incidental pain, feeling more of a stabbing character. And the neuropathic component requires also the presence of other sensible plus or min symptoms such as hypoesthesia, hyperesthesia, allodynia. And we can, the pain syndrome can start immediately after surgery, but it can also be, we also see onsets of pain after months or even years after the breast cancer treatment. Fortunately, in most of the patients, the pain intensity decreases within the first 6 months, but there's still a substantial number of patients who suffer from pain after that. We can differentiate 3 different types of several different types of neuropathic pain. The most frequent one is caused by damage of the small branches of the intercostal nerves, especially of the intercostal brachial nerve here. Can you see that when I show it, point to it? Well, hopefully. The more continuous burning pain localized in the thoracic wall is supposed to origin in the damage of sympathetic nerves. In some patients, we can find neuromas in the area of the scar or in the lateral axilla where the intercostal brachial nerve is cut. And then another important component, which is often not mentioned by women, is phantom phenomena. While phantom breast pain itself is not so frequent, about 35% of the patients with postmastectomy pain also suffer from phantom sensation in the breast and also in the lateral thoracic wall. These non-painful sensations can usually feel like a swelling or a heaviness. The standard treatment, the standard treatment of postmastectomy pain still is pharmacological treatment, and here I show you results of that are shown in an excellent review by TED about the postmastectomy pain syndrome, all the aspects of postmastectomy pain syndrome except for interventional pain therapy. But the standard treatment of postmastectomy pain is still pain medication, and especially anti-neuropathic medication. In a nutshell, 3 cyclic antidepressants are the remedies of choice for this pain syndrome. If this treatment fails, one can combine the antidepressants with gabapentinoids, or in case of intolerable side effects, choose for capsaicin patches or lidocaine patches. In this review, unfortunately, also opioid therapy is named. I would advise you to only consider temporary opioid use for the treatment of postmastectomy pain. What are the options for interventional pain therapy? Targets for localized anesthesiological interventions are the intercostal nerves. Here, the dorsal root ganglion of these sensible nerves, and the thoracic sympathetic chain, and the stellate ganglion, and for future interventions, also the fascia of the thoracic wall. Yes, for the more localized and more incidental pain complaints that can be attributed to lesioning of the intercostal nerves, I advise you to start with paravertebral intercostal treatment with pulsed radiofrequency. Here I show you the results of a retrospective study I did myself, in unfortunately until now only published as a poster at the IASP. Well, however, I examined 23 patients with neuropathic pain as confirmed with quantitative sensory testing that was refractory to conservative treatment. And as you can see here, I find this very interesting myself. These patients had clear neuropathic pain because of damage of the intercostal nerves that caused reduced thermal and tactile sensitivity, with also phenomena of sensitization, central sensitization, as you can see here. What I did for these patients, I treated them with paravertebral pulsed radiofrequency of intercostal nerves. Here you see the electrode. It's positioned right here at the intercostal nerve. And we treated 1 or 2 intercostal nerves as suggested by test blocks we delivered to these patients. Here you see the lateral fluoroscopic view, and in most of the patient, the pain intensity decreased with 60% from an average of 5 to an average of 2 on the numerical rating scale. The post-interventional nerve testing reveals almost no changes, but an improved sensible thresholds for thermal and mechanical stimuli, and central sensitization was reversed after the treatment. However, my own study unfortunately had only a short follow-up, and these colleagues, Heta, published only this year, a comparable study. They compared paravertebral intercostal nerve treatment with a treatment of the dorsal root ganglia at the intercostal nerves 2, 3, and 4 with paravertebral treatment, the way I did it, of 3 nerves. And they randomized 58 patients to the 2 groups and had a 6-month follow-up, where they found that in 80% of the patients that were treated with pulsed radiofrequency to the dorsal root ganglia, the pain intensity was reduced with more than 50%, as compared to 45% in the paravertebral treatment group. Also, in the dorsal root ganglion group, 52% of the patients could discontinue their pain medication, as compared to only 7% in the paravertebral group. Surprisingly, patient satisfaction was equal in both groups, and also surprising to me, the authors recommend, despite the favorite result for dorsal root ganglion treatment, the treatment of paravertebral intercostal nerves, because the access to the paravertebral axis is easier than the dorsal root ganglion axis. Well, next step in the treatment of post-mastectomy pain could be the treatment of the sympathetic chain. And here we find another study from the same group around Heta, from Heta, also published this year in Pain Practice. They treated 66 patients with either radiofrequency treatment of the sympathetic chain at the levels of the 2nd, 3rd, and 4th thoracic vertebra, and compared that with a subcutaneous placement of the electrodes. And what they then found in their study was a more than 50% pain reduction after 6 months, apparent in 83% of the radiofrequency group as compared to 60% of the sham group. Pain intensity was significantly lower in the radiofrequency group, and the global perceived effect was higher. A substantial percentage of patients in the radiofrequency group could also discontinue their pain medication, and 32% of the patients required monotherapy with duloxetine after the treatment. In the sham group, all patients were still on pain medication after 6 months, and of these, 75% even needed a triple combination of duloxetine, pregabalin, and tramadol. An older study of Abbas published 10 years ago, I still find this a recent study, however, is the treatment of the stellate ganglion for postmastectomy pain. They randomized 50 patients to either a classical anterior approach or an oblique approach of the stellate ganglion at the 6th cervical vertebra, and they applied then 5 milliliters of bupivacaine to the ganglion 3 times in intervals of 1 week. And, well, not surprisingly, the effect of the treatment was the same in both groups. Here, T7 means after 3 months. So the pain intensity decreased in all of the patients, and in all the patients, the morphine dose could be reduced from as high as 160 milligrams to 60 milligrams a day. I like this study, especially because Abbas also examined the the size of the area that was allodenic on the thoracic wall, and they found a huge decrease of this allodenic area from 30 square centimeters to 5 centimeters after square centimeters after 3 months. Yes, yeah, but however, the fluoroscopic approach to the stellate ganglion is more and more neglected because the ultrasound-guided procedures are safer than the fluoroscopic procedures. And the same group from Abbas, they performed another study where they compared pulsed radiofrequency treatment of the stellate ganglion with with radiofrequency treatment, and they found, this was a study where they examined more than 60 patients, and they found a substantial decrease of pain intensity in both groups, which was better in the radiofrequency group. And they also found a reduction of pain medication in both groups, which was also greater in the radiofrequency group. These authors, so Abbas, they recommended, they concluded that the combination of fluoroscopy and ultrasound guided is assumed to be of added value when performing treatment of the stellate ganglion block, and this leads nicely to the procedures where Amitabh is the expert, the ultrasound-guided procedure. This is a publication of his group about this. Unfortunately, all the ultrasound-guided techniques have not been examined for the treatment of chronic post-mastectomy pain. They already have a place in the perioperative treatment, but not for chronic post-mastectomy pain until now. So the most relevant studies come from the Memorial Sloan Kettering Cancer Center. Here, a case series of 8 patients where with thoracic wall pain and with a serratus plane block, the branches of the intercostal nerves that surround the serratus muscle are anesthetized. The serratus muscle, as you know, maybe is a muscle that has a fan-like structure. It origins in the first 9 ribs and converges posteriorly to the tip of the scapula and forms the medial wall of the axilla. The intercostal brachial nerve is also involved in these structures. Well, the study Zoka published showed that in 8 patients treated, a reduction of pain intensity of 25 to 100% could be reached, and the duration of this effect was up to 3 months. The next study I would like to show you about the ultrasound-guided techniques is also from the Memorial Sloan Kettering Cancer Center, where they retrospectively reviewed the charts of 4 years, and they identified 170 patients who had undergone different kinds of blocks. All in all, they had performed 350 blocks, and most of the blocks, as you can see here, targeted the intercostal nerves and the deep and superficial serratus plane. In most of the patients, the deep serratus plane, or a combination of both. What they found was a mean pain reduction from 7 out of 10 to 3 out of 10, and among the responders, the mean pain relief duration was 1 to 3 months. They did not have any adverse events, but what I found astonishing was that the reduction of pain medication as a result of this good pain relief was only about 10%. Yes. As a summary of the studies that I'm aware, I would advise the following algorithm. For the more intermittent lancinating and stabbing pain complaints, where you can identify somatosensory nerves having been lesioned, most of the time an approach of the intercostal nerves with whatever technique, be it ultrasound guided, be it fluoroscopic, it could be paravertebrally. It can also be an approach of the dorsal root ganglion. So I advocate these blocks for the treatment of the more lancinating incident pain, and one might in the future also choose the deep serratus plane block for this. And for the more continuous, sore, dull, and burning pain, which is supposedly sympathetically maintained, where there is no clear sensible deficit, one could use the thoracic sympathetic chain blocks or radiofrequency treatment, or the stellate ganglion block when the pain is located more in the axilla or arm. And also in this case, you can you could use the deep serratus plane block. I would like to add that in case of neuroma pain, when you identify neuromas, you can also consider sending patients to plastic surgeons or neurosurgeons to resect the neuromas or perform an intervention called lipofilling. Yeah. Well, however, all the presented studies show that despite reducing pain intensity, most of the patients still need some kind of analgesics. And when we have failure of therapy, we also have to take into account that the pain problems of patients after breast cancer treatment can also be caused by other structures. Patients have undergone a complex treatment, not only surgery, but also radiation therapy and chemotherapy. They might have had plastic reconstruction surgery. And as you can see, the list of differential diagnosis of incidental or continuous pain in the area of the ventrolateral thoracic wall and the shoulder is very long. Here I show you the 5 syndromes I consider to be to appear the most frequent. The most frequent one are shoulder complaints. Shoulder dysfunction is diagnosed in about 1/3 of all the patients treated for breast cancer, and the shoulder pain is caused by muscular disbalance after surgery by denervation of the shoulder muscles, and the adequate treatment for that would be physiotherapy. Here you can see something that is called axillary web syndrome. It's a syndrome that appears more in the acute phase after surgery, mostly in the period where patients undergo radiotherapy. It's a degeneration of venous and lymph vessels. The treatment of that is either wait and see, because it disappears spontaneously after 3 to 4 months, or manual therapy by physiotherapists. This one presents another complication of radiotherapy, osteoradionecrosis, and this pain appears after 1 or 2 years after the treatment, but mimics the more lancinating pain. But in contrary to the neuropathic pain syndrome, pain is classically triggered by taking a deep breath or bending movements. The treatment for this pain should be hyperbaric oxygen treatment. And the last one shows a reaction to radiotherapy, which can be acute and chronic and cause continuous burning pain. The treatment of that would be NSAIDs, or sometimes even corticosteroids. The most important differential diagnosis of pain in the treated area, of course, is a recurrence of the disease. One should always consider that as a reason for pain when the pain increases despite all treatment options or treatments performed. And I cannot close a talk about post-mastectomy pain without emphasizing that patients with pain after breast cancer surgery or treatment usually suffer from a lot of other symptoms and signs that are connected with the treatment. They suffer from sleeping problems, concentration problems, and anxiety. And if you treat pain complaints in these patients, it should always be in a optimally be in a multi-disciplinary setting. Well, that was it. Thank you very much for your attention, and I'm happy to take questions if you have some.
Thank you very much, Dr. Lucas. That was a wonderful capitulation of how we can help our patients. I wanted to give a couple of minutes for any questions. And while we're waiting for anything in the chat, I did have one technical question. Have you changed your pulse radiofrequency settings over time? For example, I've noted that I've done more pulses per second over a longer duration of time to get some of the effects from pulse radiofrequency. So I just wanted a technical question from you, and answer from you on how you've changed, if you've changed your technique, or what your technique is when you pulse these thoracic nerve roots in terms of the variables.
Yeah, well, I didn't. I choose for. Thank you very much for your question, because I forgot to say that I choose to treat the paravertebral nerves with a 6-minute algorithm instead of a 4-minute algorithm we use for the treatment of lumbar radicular pain, for instance. Yeah, but I didn't change the other parameters. Did you?
I've tried 5 milliseconds, 50 hertz, those kind of things. I just don't have any personal, one is better than another, other than time seems to make a difference. So I just wanted some of the other thoughts from some of other colleagues that they have done this. Any results that have been different from previous just by changing some of these settings? Yeah,
but I always treat my patients with a temperature control. So I never go further than 42 degrees. That is very important. And I think, I'm not aware of studies that examine this also for other pain syndromes.
Excellent, thank you. We do have one question from the audience asking, what about the erector spinae plane blocks? Any thoughts on how to implement this for post-mastectomy pain?
Yeah, that's a good but difficult question, because there's most of the ultrasound guided blocks, there's only studies published in the perioperative period. And when we see patients in a chronic pain setting, I have no experience with this block, and I couldn't find a publication about it, but maybe you are more of an expert, Amitabh, about that. I'm not very experienced with ultrasound guided blocks.
We've done a few erector spinae pain blocks with corticosteroid. I have not done neurolysis. I can ask some of my colleagues. In general, we've been able to focus more on the lateral planes, so to speak, superficial plane. And I know one of the questions here was what type of injectate, and we tend to use local anesthetic bupivacaine, 9 mLs, and then 1 ml of the corticosteroid, particulate steroid. And I don't think there's much difference between dipomedrol or triamcinolone. So we haven't had too much experience with the erector spinae plane block for mastectomy pain, but we use it quite often for the posterior thoracic and the posterior thoracic paravertebral pain, and then the thoracotomy pain.
Yeah, Well, supposedly you will have some effects. I mean, wherever, as I said, wherever you target the intercostal nerve or the branches of the intercostal nerves, that's good. So I think whatever you use is okay. But with all the blocks using local anesthetics only, just keep in mind that the effects are not for the long term. It's usually some weeks or months that you can have effects, but the more intense treatments with pulse radiofrequency or radiofrequency of the sympathetic chain, they have long-term effects as well.
Excellent. Thank you. Well, I guess maybe one last question and we'll move on. Any place for radiofrequency or neurolytic phenol block for neuroma treatment?
Yeah. Well, you could try that, but the treatment of peripheral nerves with neurolytics is, in my opinion, reserved to the palliative period and not to patients that, well, most of the time survive breast cancer treatment or breast cancer. Yeah.
I tend to agree. I will say one thing we found a physician a plastic surgeon in Washington, D.C., who were able to find the branches that have been cut from intercostal nerve, and they can reanastomose them. So if you have a possibility of a reanastomosis, there are some techniques in plastic surgery and our nerve surgeons that may be able to do conduits and those kind of things. Anyone else have any advice from our panelists or faculty?
Thank you very much, Dr. Lucas. I have just one question about peripheral nerve stimulation. There is how there is a place of peripheral nerve stimulation for this indication in your practice?
Well, I don't use neurostimulation myself, and there is only some cases published in the literature about it. This might be an option for the future, but I think there's not enough research done about that to recommend it.
We have a handful of patients that we've done the paravertebral nerve with peripheral nerve stimulation and intercostal nerve, and it's been helpful, but it's not been dramatically where we would say this is the option to do for all of our patients. But we have a few patients we've tried so far.
Yeah, like with all the neurostimulation techniques, the patient selection is extremely important. And I think I've treated a lot of patients with postmastectomy pain syndrome. If you can't treat the pain with conservative methods or some intervention, you should also focus on other options, more addressing the processing of pain in the central nervous system, I think. Because don't forget, these patients, they will live on. It's not a temporary concept, this.
Dr. Lucas, that was wonderful. Thank you for your expertise. And hopefully sometime soon we will see you again in some part of the world.
Same here.
Next, we're going to have my dear friend and colleague, Dr. Porras, Carolina, and she's visiting us. Well, not visiting us. She's helping us from Mexico. And, I've had an opportunity a couple of years, maybe even last year, to visit her and all the wonderful work and care they take care of in Mexico City. And I thought it'd be wonderful to have her part of this program and giving her insights. And while they've done so many different things for cancer pain management from over the years, I thought it'd be interesting to see how they manage visceral cancer pain, especially in a part of the world where intrathecal drug delivery is not as common. And so a lot of these techniques of neurolytics, cementoplasties are much more common perhaps in Mexico. And I think the expertise would be much appreciated. So, Carolina, thank you for joining us, and wonderful to hear your experiences.
Well, thank you, Amit, for the invitation, and thank you all for being here on Sunday. And hope everybody is okay, as well as their families. Do you hear me and see the presentation, right?
Yes.
Yes.
Because, okay. So, undertreated cancer pain associates both physical and psychological consequences, and persistent pain can cause existential and spiritual suffering, which can limit the patient's coping skills. So it's very important to control it. I'll talk by cancer type pains. Lung cancer pain can presentate with somatic, neuropathic, and visceral, parietal, or pleuritic pain. But this lecture is focused on visceral pain, which is not the most frequent presentation of pain in lung cancer, because we have a wide variety of pain syndromes, like chest wall and metastatic bone pain. But for pleuritic pain, we reported some experience with erector spine plane block with a 48-year-old woman, which presented at the pain clinic with shooting and burning severe pain on her left thoracic cage. And it increased with deep inspiration. It had two components, neuropathic and pleuritic pain. So we performed the ultrasound-guided ESP block at T5 transfer process with 20 millimeters of bupivacaine with 40 milligrams of methylprednisolone. It lasted only 1 month. 1 month later, the patient complained again of pain with visceral and neuropathic characteristics, and a new PET CT demonstrated cancer progression. So we performed a lytic ESP block based on a report of the peripheral capsular nerve block with lytic phenol. So we thought that it could be an option for our patient, and then we performed the in-plane block with ultrasound and corroborated the spread with CT. The total volume administered was the total volume was 12 milliliters of phenol at 6%. And the analgesic response was for 4 months. However, the patient had the same opioid consumption but a reduction in VAS, and she died in the 4th month post-ESP block. I tried to find some evidence about ESP block, only randomized trials with laparoscopic cholecystectomy, and for chronic cancer pain, I couldn't find a good evidence. Most of the evidence is for postoperative and some chronic randomized trials. Following sympathetic blocks in gastrointestinal and gynecologic cancer pain, neurolytic blocks of sympathetic waves at different levels have been used for decades. Celiac axis is the only sympathetic structure that can be blocked through two different approaches, celiac and splanchnic block, and both have celiac neurolytic and superior hypogastric block had been used for the treatment of cancer pain. They have been described fluoro, ultrasound, and CT guided. My experience is fluoro and CT guided. At the National Institute, we have access of the fluoro and CT and CT guided techniques. The ultrasound is ours, and I have done just one hybrid CT and ultrasound guided celiac plexus block. So let's start with celiac plexus brachii. This is a very nice review. If you understand well the anatomy with CT, you can reconstruct and understand the ultrasound anatomy. Here it's the liver corresponding to this structure, the aorta, and with a transverse probe, you can visualize the aorta and the celiac trunk with both arteries here, and the hyperechoic image that you see is the celiac plexus brachii. And here, deep in the image, is the vertebral body. Here you can visualize the needle just next to the celiac plexus brachii. The target typically is appearing as an hyperechoic grade zone surrounding the celiac trunk, cephalal, and laterally to the trunk. It has been described that the anterior approach eliminates the risk of accidental neurolytic spread to some structures, including the neural axis, but it is difficult. You really need to have a very good probe. Splanchnic plaque, which we have many experience. There are two techniques described in the literature, the paravertebral and the transdiscal, which is the one we performed at the National Institute of Cancer that Dr. Plancarte designed. It is important, the most important tip is where to place the needle. It's important, here you see the articular pars, and this space between the pars and the costovertebral union. It's very important not to place the needle between the rib and the costovertebral union. It's important to place it here in this space, because if you place it here, you can expose the patient to pneumothorax. The more you oblique the X-ray, the more central the tip of the needle will be. So it's important for us to the final image to be just at the center. But if you do a very oblique right or left projection, you can open this space, which is the one you don't want to approach. This image is with contrast medium and air, and the final image is this. We apply usually 10 milliliters of phenol at 10%, but our population is short, so I don't know, maybe for biggest patients, you should use 12 or 15 milliliters of phenol. We don't have alcohol, so in Mexico, so we don't use alcohol. And besides, because it's diffusibility, we don't use it. For superior hypogastric plexus brachii, this is a transdiscal approach, the classic approach. The classic approach was performed just when it was described in the 90s by Dr. Plancarte. It's important to mention that in Mexico, the access of fluoroscopy was difficult, so Dr. Plancarte designed it with just X-rays, so they had just the opportunity to give 5-6 X-rays. So that's why it's described in AP and lateral position only. You didn't have the opportunity to give any obliquity. It's if you see Dr. Plancarte performing it, it's easy. However, don't tell I said that, but it's much easier with transdiscal approach, because here you have to reconstruct the image in your head, how how much you're going to advance the needle, but you are in an AP position. You have to enter from lateral to central, and you can touch the disc. So it's like an hybrid procedure sometimes, disc with a classic technique, and it's performed with two needles. And this is the final image that you have to see. We perform it also CT guided. It's much easier for me to perform the classic technique, the two needles lateral. But if you're going to perform it with a transdiscal approach, you have to check, just like in the transdiscal splachnic block, this space. The more lateral you approach it, the opportunity to get at the center, it's better. Here, if you don't give it a lateral, an oblique, a good oblique, the needle, the point of the needle, and the contrast medium would just be not in the center, just in one side. So in this case, you can redirect the needle or make a two approach with the two needles, but transdiscal. This can make the disc suffer, L5 as one disc to suffer, and it's not well described. It could be extruded, but better angle, adequately angle the fluoroscope before you performed the block. And this is the final vision with air and contrast medium. We usually use 5 to 10 milliliters of air just to get this image. And because sometimes when there is many retroperitoneal tumor, you can find resistance when applying. So those are the cases when we apply more air and more contrast than usual in cases of advanced cancer. This is a trial of 30 patients that compared the transdiscal versus a classic posterior approach in pelvic cancer pain, and they found that it's easier, safer, and more effective, the transdiscal. In the ultrasound, here. You can find, with the CT, you're looking for the disc, the intervertebral disc of L5 and the sacrum. With a transducer proof, you can see here the vertebral body and the aortic bifurcation and the common iliac arteries. Then you check it in a longitudinal sonographic image showing the sacrum, this characteristic of the bone, and the intervertebral space, the disc, and the L5 body. You can approach it in an out-of-plane technique, just between the retroperitoneum and the disc. And here it is how the needle should be seen, or at least the point of the needle, because it's an out-of-plane approach, and the spread, the black anechoic spread. When I perform it, I usually use a Doppler just to see the spread of the lytic agent, as well as you can feel the resistance because sometimes you could be just in the disc. What is the evidence of sympathetic blocks? Well, celiac plexus block, regardless of the technique used, improves analgesia and decreases opiate consumption. In superior hypogastric plexus block, patients report a decrease in pain intensity and less morphine consumption. However, the quality of these studies are generally poor due to several limitations like sample size calculation or no intention to treat analysis. So on the basis existing evidence of 2015, celiac block has strong recommendations in patients with pancreatic cancer pain. And we performed a review that I think it's we performed a review of superior hypogastric plexus block, but the slide is, I don't find the slide, so let's move to water ganglion block. This is a classic technique with the spinal needle just in a C way and the transiscal approach. This again, like hypogastric block, it's easier to perform the transiscal approach. In this approach here, you can see, because it was a real-time fluoroscopy, you can see even a finger there, right? This is the finger. Dr. Plangarta again did it without guidance sometimes in the 90s. And he, just to feel that he's not punctioning the rectum, he placed with another glove an anal rectal touch. I don't know how to say that. So to make sure the spinal needle is not functioning in the rectum. Oh, this is a retrospective study about the superior hypogastric plexus block with 180 patients. The success rate of pain control was 49.50% at 3 months, with a significant reduction of opioid consumption only in 12.50% at 3 months. There was no significant statistical evidence related to either opioid consumption or functionality of the patient before the blockade as a variable that can influence the success of the procedure. There are some other devices for treating visceral pain, like intrathecal drug delivery. The indications are refractory pain disease that in states of malignant and non-malignant origin, and can be categorized in nonsusceptic, neuropathic, and mixed pain syndromes, and often subcategorized into visceral and somatic pain. Refractory pain is pain that persists when multiple evidence-based treatments have been attempted and desired endpoints of pain reduction return to acceptable function, and absence of intolerable effects of pain have not been achieved. I think in the two last lectures, you are going to talk about the intrathecal therapy, which has strong evidence, and about the spinal cord stimulation. We have more experience in these patients with non-cancer pain, for example, for pudendal neuralgias, because in Mexico, the economy is not as good. So many cancer patients cannot afford the stimulators or intrathecal therapy. So it's in our private medicine, which is mainly non-cancer patients, where we perform both intrathecal or stimulators. The conclusions are undertreated visceral cancer pain associates both physical and physiological consequences. Sympathetic blocks are easy to perform, cheap, safe, and can control pain for a limited time. It's important to tell that to the patient. Only one randomized trial suggests that if the block is done in early stages of cancer, the analgesic response for the patient would be better, and implantable devices have demonstrated effectiveness in this type of pain model. However, we still have to make some research, especially in spinal cord stimulators. Thank you. This is downtown from Mexico City, which Professor Vissers and Amit knows well. Thank you.
Carolina, that was wonderful, and I appreciate all the hard work you and obviously all of our mentors, Dr. Plancarte, have done, and teaching all of these various techniques. And I know there's going to be lots of questions, but I wanted to start the conversation with one question, which I think you and Dr. Shushma Bhatnagar is also on. Maybe she can also help and ask. Is at least in the United States, we cannot take an ultrasound machine to a patient's house and do a procedure for pain. But in other parts of the world, that might be the only way to get cancer pain relief. Do you have experience or any thoughts on taking an ultrasound machine to someone who's dying from abdominal cancer and doing a celiac plexus block? And does that happen in Mexico? And obviously, and Dr. Bhatnagar can chime in India, because it seems like in other parts of the world, the ultrasound may allow it to do some of these things that we could not do in the United States, where people have to come to our facility for pain relief.
The only thing that we do just in the house of the patients are intrathecal neurolysis. They are safe in terms of complications, in life-threatening complications. My machine, because it's I don't know, it's curious that in the National Cancer Institute of Mexico, we have access to CT and fluoro, but not to ultrasound machine. So the ultrasound machine we use is mine or another colleague, Angel. So my machine is portable. I'm just in the carb or sympathetic blocks guided, so I won't be able to perform it in a house. No, I'm just kind of starting with hybrid procedures, CT, with my machine. But I don't know, it's a good idea.
So in India, Abhitab, in India also, it is not possible to take ultrasound machine at home because of PNDT Act. That is, we can take ultrasound on bedside. So we are doing a lot of ultrasound guided celiac plexus and hypogastric plexus block in supine position bedside, but never at home. So we have never done it home.
But that's still very good to hear that you can do this in bedside, which is very helpful for a lot of our patients, especially in facilities where they don't have a CT or a fluoroscopy machine.
Yes, it is, because patient is very comfortable in this, because it is always difficult to make him prone when they are suffering with cancer and they are in pain. And most of the time, patient also it is always difficult to find a vacant slot for these in CT room or in operation theater. So it is always better for patients as well as for the comfortable. Everyone is comfortable when we are doing bedside ultrasound guided block. But although when we are doing bedside ultrasound guided block, we have a station where we take all the aseptic precautions. So it is not that when we are doing, so it is out of OT, so but still we take all aseptic precautions when we are doing bedside ultrasound guided block.
Dr. Polas, good morning from California. This is Xiang from Stanford University. It was really exciting, a very interesting talk. I myself does a lot of CT guided and ultrasound guided visceral pain procedures at Stanford as well. I have a few questions for you. The first question is about the pheno. I use phenos 100% for my trigeminal ganglion block, which I will share with my colleagues here later. I wonder, when you choose 10% of pheno for your ESP neurolysis and other neuroplexus neurolysis, I wonder why you choose 10%, and can you share your experience, how effective it is? Do you consider the safety of pheno? Therefore, you choose the lower concentration of pheno at 10%. That is my first question. My second question is very interesting. Your celiac plexus block, abdominal ultrasound guided, is really beautiful picture. Do you have any concerns for people who are overweight, or you always offer this position for people who are, with normal BMI, for safety concerns, for better visualization concerns? Thank you. That would be my two questions for now.
Okay. Thank you, Dr. Kwak. The first is just that it was the lytic concentration, because you know that a funnel, it's anesthetic or antiseptic or lytic, just producing Wallerian and degeneration in 10%. So we use it in 10%. That's why we haven't. It would be actually very interesting to try just to maybe compare 10% versus 15% or 20% phenol in this kind of blocks, and to see if we can achieve a longer or better analgesic response. We take into account that sometimes we perform splanchnic, hypogastric, and ganglia block at the same time. So we are just in the 3 grams dose of maximum dose of phenol. So many of our patients with liver metastases and retroperitoneal at L5 as one metastasis. So we performed both. We haven't published that, but it would be interesting. There is some I think 1 or 2 reports about it in the literature, but that's why we use it in that concentration, and specifically in ESP block. We had a little bit of we were afraid because it was the first reported ESP lytic block, and since the structures are paravertebral and foraminal distribution, we try just in base of our few complications of migration of, for example, in sympathetic block to the foraminal. We thought that it would be safer for the patient. And actually, in the report is the patient complained of neuropathic pain just at the liver. It lasted only 2 or 3 days, but she did complain of neuropathic after the procedure, just in the side lateral, like the intercostal nerve. So that's why we performed 6%. Maybe we're studying if the percentage, the best percentage of for ESP block, and we haven't get to that yet.
Thank you, everyone. I guess we have one last quick question, then we'll move on. We have a question in the chat that asking, which intervention would you perform for non-surgical advanced bladder cancer pain?
It has been described that the sympathetic block, lumbar block can work, and hypogastric plexus block can work as well. Maybe a diagnostic and then the lytic block if the response is adequate.
Yes, I think that's probably, I agree, that's probably the most conventional first treatment step. So thank you very much, Carolina. It's been a pleasure to have you part of this program, doing wonderful work there, obviously, and be safe in Mexico. Say hi to all my friends and colleagues. And I hope you can stay on as much as you want, because hopefully you can help give some advice for our colleagues in Morocco, okay?
Okay, thank you.
Thank you, Dr. Carolina Hernandez, for your presence, your support. Dr. Amory from Morocco, and it was my pleasure to have that wonderful, nice presentation. Thank you very much.
Thank you very much for the invitation. Bye.
And next we have, Amin, who's hoping could probably, if you don't know him by now, I don't know what to say, who's going to give us his thoughts on how they're using the botulism toxin for their cancer-related pain. And ourselves, Dr. Chen and myself and Memorial Sloan Kettering have just started gathering some experience. It'd be wonderful to hear your thoughts on that program and how that can be helpful for our patients.
Thank you very much, your friend, and thank you for all the faculty for the presence and the lecture. I will take just a few minutes to talk about botulinum toxin and cancer pain updates. The use of botulinum toxin is employed in treating post-stroke spasticity, cervical dystonia, and muscle hyperactivity. We can use botulinum toxin for treating chronic migraine and autonomic dysfunction, but recently the use of botulinum toxin was increased in the management of pain, of musculoskeletal pain and neuropathic pain. We have more and more studies about neuropathic pain. We'll see that in this presentation. The mechanism of botulinum toxin in pain relief was initially associated to muscle relaxation, but we will see botulinum toxin will be the future of the treatment will be a coadjuvant in the future of the treatment of pain. And what is the mechanism of action for the botulinum toxin? The mechanism is normal neuromuscular junction, the release of acetylcholine from the synaptic vesicle in the presynaptic neuron is mediated by soluble N-acetylamide sensitive factor attachment protein receptor. This is a protein of neurotransmission. After released from the presynaptic neuron, acetylcholine binds the nicotinic receptor and induce the potential action in the postsynaptic neuron. This is the normal neuromuscular junction. If we inject the botulinum toxin in this junction, in this neuromuscular junction, the action of botulinum toxin consists in a heavy and light chain, and after entering the neuron by endocytosis, the botulinum toxin is disconnected and the light chain is released to the cystosol. And what we have a clave of this protein, this neurotransmission protein, and further inhibits the release of acetylcholine from the synaptic vesicle. It induces a muscle relaxation. That's why we use this botulinum toxin to treat spasticity, muscle dystonia, and all the problem or all the muscle pathologies need a relaxation for for this muscle. What do we have as botulinum toxin in the world? We have two serotypes. Botulinum toxin A and B. We use more botulinum toxin A in our practice and less botulinum toxin B, and we have a lot of serotype and a lot of name in this subject. The mechanism of action, we have seen the mechanism of action for botulinum toxin in spasticity or in muscle relaxation, but there is another mechanism of action was described by recently this year by treating anti-nociceptive and neuropathic pathways in cancer pain. This is a novel use of botulinum toxin to ameliorate the treatment of cancer pain. And the mechanism of action, there are two mechanisms of action. The first is muscular level. This is inhibiting the release of acetylcholine at presynaptic level and blocking action of potential in the neuromuscular junction. The second mechanism is anti-nociceptive level, and it consists on inhibition of secretion of the pain mediators. Pain mediators is a substance P, glutamate, calcitonin gene-related protein from the nerve. This is the mechanism is inhibiting the secretion from the nerve ending and from dorsal root ganglion, as it impacts directly the nociceptive transmission and indirectly the anterolateral and trigeminothalamic system. We have two levels in this way. The action in the peripheral nerves systems by inhibiting the inflammatory and inhibiting the neurotransmission protein or substance and glutamate protein S, and this inhibition conducts to indirect action of the central nerve system by blocking the transmission of neurotransmitter CGRP and substance P to central sensitization. That's why we use botulinum toxin. We start to use botulinum toxin in cancer therapy. In this study, you see the effects of local administration of botulinum toxin on tumor perfusion and treatment. They use typically MRI image of fibroblastom, fibrosarcoma tumors, so in the perfect pixel 3 days after single injection of botulinum toxin or vehicle. Botulinum toxin is red, this red start, and for orange is vehicle. B and C is the effects of combination of botulinum toxin with cytotoxic treatment. B is treatment with radiotherapy, 20 gray, and C is treatment with cyclophospholamide, and this is chemotherapy. Note that in this way, you know that botulinum toxin alone don't exert any cytotoxic effects, but when we combine botulinum toxin with cytotoxic treatments, as you see here, when you combine these two treatments, you will have the decrease of the tumor, and if you see the tumor size decrease if you use both cytotoxic treatment and botulinum toxin. It's a new way to perhaps in the future to treat not just cancer pain, but to reduce the tumor, and the size of tumor is very important perhaps in the future to use botulinum toxin for this area. A review of literature of botulinum toxin with cancer. We have sorry, we have manuscripts, 746 manuscripts, and we have the final review, 64 article or manuscripts with the effects on cancer line, the muscle spasm and pain due to remote muscle lesion, and pain due to direct pressure from local cancer. And we have post-surgery or post-radiation pain. This is, we will start with botulinum toxin therapy for post-radiation and post-surgical cancer pain. As you see here, there is a lot of study who are defining, for example, the location of cancer, the treatments, for example, radiotherapy, chemotherapy, mastectomy, surgery, and radiation and surgery, the location of cancer, head and neck, breasts, and head and neck, and the primary outcomes. We use VAS, pain VAS assessment. We can, in all these studies, what do we have as a result? To have complete pain relief and less pain in the majority of this manuscripts. And as you see here, there is significant reduction of pain or improvement of pain, improvement of function, and both improvement of pain and function when we use botulinum toxin for treating pain after head and neck cancer or breast cancer. Post botulinum toxin, we can use this therapy for treating post-radiation or post-surgical damage to parotid gland. What we have as complication, we can have gustatory hyperhidrosis, post-parotidectomy ciliary fistula or cell formation. As you know, we use botulinum toxin for reducing the ciliary or for reducing the hyperhidrosis in other indication. But in the indication of reducing ciliary or hidrosis in the post-surgical or post-radiation damage, especially if you have head and neck cancer, as you see here, we have a post-parotidectomy fistula and gustatory swelling after parodectomy. The injection site is parotid gland, and in this study, they use facial skin. The results within 6 weeks after surgery, fistula healed in 9 of 10 patients is a good, very good result for this indication. And as you see in other manuscripts, we have a very good result after 14 months or after 1 year, is complete loss of swelling after this indication. I think it's very good to know that we can use this botulinum toxin injection for this indication, and in this study you have a good results. The third indication is malignant tumors and cancer cell line. This is we start to think about reducing the malignancy or reducing the size of tumor. And here you have a review of the study. The majority of study is in vivo or in vitro, and as you see, we have a lot of study that's they told about reducing tumor size, about prostatic cancer, glioblastoma cells, breast and colorectal cancer. But the problem with this study is the open study, the not randomized, not controlled study. Is the new way to to start this treatment, but we need more study for defining how and what is the effects and side effects, complication of this type of treatments. In vivo, you have prostate cancer, fibrosarcoma, hepatosarcoma, and as you know, some study there is no effects, and some study there is more effects, but we need more study for defining this technique. Here I make you another indication. In our practice, we see this indication more and more. This is Raynaud phenomenon, patient with lung cancer or with other cancer, and this is benefits of botulinum toxin injection in this indication. As you know, the botulinum toxin have a role in vasospastic disorder of the hand, and in this characteristic of primary versus secondary Raynaud phenomenon. As you see, the secondary Raynaud phenomenon is associated with autoimmune disease. The age is under 30 years. The pain is frequent. The finger involvement is asymmetrical, and this is dilated with vessel wrapped in nail, and frequent onycholysis and antibodies. This increase titers, and the necrosis will be frequent. This is an algorithm about Raynaud phenomenon. How do we treat Raynaud phenomenon after, for example, lung cancer? The botulinum toxin can make action in vascular smooth muscle mitochondria or in oxygenation of more perfusion and oxygenation of tissues with vasodilatation using nitric oxidase. The role of botulinum toxin, the indication is for patients with ischemic digits of Raynaud phenomenon or vascular insufficiency. And there is a contraindication for use of botulinum toxin in this area, in this indication: allergy, pregnancy, breastfeeding mother, active infection, myasthenia, and patient on medication that decrease neuromuscular transmission. As you see, that quinidine, anticholinesterase, or aminoglyceride, penicillamine, and calcium channel blockers. After the way and to inject, we inject in the skin and intradermic injection. Here, this is a patient that we have in our units. Before and after the injection, as you see, the result is very, very important, and we have a good result for this patient with Raynaud phenomenon. As you see here, I have digit ischemia, and after the injection, this is a good, very good result with a good reperfusion or oxygenation of the digits. The efficacy, other indication that we can use the botulinum toxin is treatment of painful cutaneous leukemia. Botulinum toxin is associated with improvement in skin-related quality of life in individuals with cutaneous leukemias, and specifically the injection of botulinum toxin skin reduce pain intensity, and the mechanism is transcholinergic mechanism or reduction of neuronal activation. How can we use, for example, botulinum toxin for treatment of upper limb impairments in breast cancer survivor? In this original article, this saying that single botulinum toxin infiltration in the pectoralis major muscle, in addition with standard physical therapy program cannot be recommended at this stage to improve upper limb impairments and dysfunction after breast cancer treatments. That's why the indication in this case is not recommended. That's why in this case we can use, as we see in the first lecture, can use other techniques. The last indication is neuropathic pain. This is an article in France's Neurology. As you see, neuropathic pain, the use of botulinum toxin in treatment for neuropathic pain, you can use it in many indications. One of this indication is post-surgical or post-thoracic neuropathic pain. And in this study, in post-surgical syndrome, what do we have? We have, for example, we have comparing with control injection of botulinum toxin. We use botulinum toxin type A, and the major finding is the injection after post-thoracotomy or post-radiation therapy, post-surgical and post-radiation therapy, post-mastectomy, and here post-mastectomy, you can try that we have a significant reduction in post-operative pain or during the final or initial expansion of cancer. It's very important to introduce this indication with other procedures or with other therapy to reduce pain or to have less intensity of pain in this indication. Conclusion, botulinum toxin have a positive results in many indications cancer pain, but we need more studies for introducing this coadjuvant treatment in the field of cancer pain treatment. Thank you very much.
Thank you very much. I mean, that was a wonderful discussion on how to use this toxin for some of our cancer patients. Do you have some experience already in your clinics of using this for cancer patients?
Yes, we start with the Raynaud phenomenon in a patient with lung cancer, and we start with neuropathic pain. We inject in intradermic area the patient with neuropathic pain. We have good results with this injection, and we try perhaps to have more patients for having good studies. And other indication that we use botulinum toxin for cancer pain, this is for spasticity after spinal cord injury, injury after, for example, radiation after surgery or after fracture. We have spasticity, and we use botulinum toxin for reducing spasticity for this patient, and we have a good return about increasing the quality of life of these patients.
Thank you. Are there any other questions from either our faculty, or I don't see any other questions in our question and answer session chat line?
I have a question, or maybe also a comment. Thank you very much for this very nice overview about the indications for botulinum injections. For the treatment of post-mastectomy pain, I sometimes referred patients to plastic surgeons that do the injections of the botulinum toxin, but that was most of the time for animation of the breast that was caused by the implants that were too, let's say, heavy for the pectoral muscle. But then on the other hand, you have to balance the repetition of these injections, because then on the other hand, you will cause shoulder instability when there is chronic denervation of the pectoral muscle. So that is, well, in my opinion, the difficulty in this in the indication. But yes, it is an important one, especially for those women with extreme animation of the breast.
Yeah. Yes. Thank you for these comments. All right. About this balance between injecting and relaxation, muscle relaxation about great pectoral muscle, and this problem of functional shoulder. This is a balance. It's very, very difficult to decide and to make indication about this. But if, for example, we can use other coadjuvant treatment like electrical stimulation, functional stimulation, we can use it, for example, during the injection time. But the problem is to have other muscle who can do the same function of great pectoral. That's why we don't have lots of study about what we will have as a result, decrease in pain or having less function. This is the problem, and I think it will be good to have a study about pain and function for these patients, because it's important to, for example, to have no pain. But if we have other procedures or other interventional procedures, we can use it for having the same function of the shoulder for this patient.
Excellent. Thank you very much again. I mean, it's been a pleasure to be. Good job collaborating with all your colleagues here, and a wonderful conference so far. I wanted to give the next session really is a discussion, and we're very happy and proud to have Dr. Shishma Bhatnagar with us, who has been a mentor to me, especially a lot of her techniques. I had the pleasure of meeting her a few years ago. I think it was in New York, but I don't remember where the WIP was then. Nonetheless, I think it'd be a good opportunity for her and also our other faculty, Dr. Porras and Dr. Lucas, just to kind of have your thoughts on how to develop a very practical cancer pain program in your country. Maybe she can give a few thoughts on at least struggles that she had in India, and then some of the questions you may have with her and other faculty so far, and even Dr. Chen and Dr. Kwan, and who are our colleagues from the United States, can chime in. But I thought it'd be good to have her perspective, which is very different from our perspective in the United States, to help you. So
Okay.
if Dr. Bhatnagar, give a couple of minutes, and then they'll ask you questions.
So, thank you, Amitabh. Thank you very much for inviting me for this important meeting of cancer pain management. Yes, this is absolutely true that when in a cancer center, without developing cancer pain management services, I think services are incomplete. So we have to have a robust cancer pain management system in any of the cancer hospital. And unfortunately, most of the time, we give a lot of emphasis on medical oncology development, surgical and radiation oncology development, and preventive oncology sometimes. But pain management, which is almost in 80 to 90% of patients, those who present in advanced stage, they are in pain, and we have to develop a robust system of cancer pain management. So can I show just few slides, and then we will, just 5 minutes I will take. So can you allow me to share my screen, please? So can you see the screen?
Yes.
Okay. So I think this is okay. So I have just given the topic that capacity building and creating an optimal model of integrating cancer pain and palliative care in continuum of cancer care. This is my topic. Uh, uh, so this, we all know that if we really want to develop any system in any of the anywhere, we have to develop a strong, robust system where roots are very strong and healthy, so that it can grow and it can give the fruits forever, whether you are there or not. So whenever we have started we have tried many models all over India to develop cancer pain management services all over India through Ministry of Health and Family Welfare. And the most robust model which has worked, I will tell you in next few slides. And most robust and most successful model. In this model, out of 28 states, we have already reached to 26 states, and all those states, we are concentrating that wherever the cancer hospitals are, there should be cancer pain management services. So the wherever this model works with the 4 objectives, that we will work for capacity building, we will educate doctors and also nurses. We give a lot of emphasis on education to nurses, and we will try to make available the medication which are important for pain. Simultaneously, we will create a system where the opioid, especially the opioid, should be used safely. And final objective is to make advocacy and policy and protocol in those particular institutes, so that patients, those who are in cancer pain, they should not remain deprived of pain management. So this program usually works over a period of 1 year. And out of 1 year, 19 days are our teaching program, means face-to-face teaching. In this face-to-face teaching, this program we have started with in the collaboration of Lian Foundation from Singapore, and this has become the most successful program. And in this program, what we do 5 days teaching, and in this teaching we teach all concepts of palliative medicine and give a lot of emphasis on cancer pain management, plus safe use of medication. After 5 days teaching, people go home, and then after 2 or 3 months, they come back for 5 days clinical attachment at AIMS, New Delhi. I work in All India Institute of Medical Sciences, New Delhi. So people come over there for 5 days teaching. Then there is a mentor for all over country, wherever this center we select, there is a mentor, and this mentor will go there for 3 days and see whether how they are starting, whether they are doing OPD services correctly, whether if they are doing intervention in cancer pain patients, whether they are selecting their patients perfectly, whether they are doing the right intervention to the right patient. And then next is refresher course, which we do, and we ask our participants center that how much they have done, and it comes around after 7 to 8 months. This turn comes of refresher course, and then this goes for 3 days, and on an average we take 15 to 20 centers at a time, and all these centers, they present that what are the developments in terms of our 4 objectives which we have created, how much advocacy they have done, how much protocols they have created, whether the medicines those should be available for cancer pain management is available, whether have you taught all other your colleagues, those who are doing cancer pain management. And so this we work on those 4 objectives. And then there is an external auditor who is not involved in this program at all. He will go and do the audit. So this lasts for a year, and after a year, what we have seen that almost in 26 states, and this has become a very successful program. And wherever it's not that we have covered all the cancer centers, but we try to cover the major institutes so that they can become a center of excellence, and they can teach other hospitals further in their states. Expected outcome, of all these are, I have told you, capacity building, opioid availability, other drugs availability, education, and advocacy. What our main aim is remaining aim of this program in terms of cancer pain management, that we have to have a balanced approach of use of opioids and intervention. So wherever intervention is required, we will do early intervention, and when intervention is not possible because of the metastatic or disseminated pain, we will do intervention if pain is of high intensity because of the single problems. We will do intervention and we'll try to reduce the medication as much as possible. So we always teach that early intervention is key of success, which will reduce medication requirement as well as quality of life. But many a times it is not only intervention which works in cancer pain patients. We have to have a balanced approach of using opioids and other medication and intervention. This is what the programs highlighted. So these are the variety of intervention which we teach to our participants. Main intervention which most of the time we work in cancer pain patients. And there is an integrated approach. We give a lot of emphasis in teamwork, that a person cannot work alone, and they have to have a team, and this team should comprise. It is not necessary that all these people are there in AIMS, so everywhere they should be there. It is not necessary at all. But we give a lot of emphasis that team should be there, so that as best as possible, patient will be benefited as much as possible, and patient will get best quality of life in terms of pain management. And these are the various to create awareness all over AIMS. When you come to AIMS New Delhi, you will find these type of posters all over AIMS. It is not only for cancer pain management. We have made AIMS pain-free hospital, so we have a pain policy, and in this policy, what our protocol says that we will teach our nurses. So almost all our nurses are trained, and we feel that this is the most unrecognized and underestimated power which we hardly use, because they are the one who are going to be there with the patient, and whatever advice you are giving, and if they will follow it properly. They can follow it properly when they will be trained. And second thing which we give a lot of emphasis on, safe use of opioids, so that opioid epidemic should not happen, because in developing countries already there is hardly opioids available, and if at all they are available, they should not be misused. So this is the safety circle which we have published and created, that all these 10 points, like developing trust between doctor and a patient, creating awareness, empowering physician, assigning the responsibilities, making it available whenever it is required, educating society, and if at all, if it is not being used, how to dispense it, supervising constantly, very close supervision, giving a lot of emphasis on total pain, because it is not the intervention and opioid work. Sometimes it is just a pain of just worry and financial pain or psychological pain or social pain, that why this has happened to me, what will happen, I will become disfigured. So this is precipitating and creating lot of intense pain. So we give a lot of emphasis on total pain relief, and finally intervention wherever or whenever, as early as possible. So all these 10 points we have created, and we give emphasis that these points should be learned before learning cancer pain management. And this is a simple protocol, that whenever patient will have pain, what duty nurse will call duty doctor, and if duty doctor can relieve pain, give medication, it's okay. If pain is intractable, then there are various pain resource team which we have created at AIMS. So that pain resource team will be called. This can be called by duty doctor, and sometimes if pain is very severe, then even ward nurse can call, and this pain should be relieved as best as possible. So final recommendation, in terms of cancer pain management, we give that early intervention is key of success. It reduces medication and improves quality of life. But integration of intervention and pharmacotherapy is super success. So it is not the intervention will work only, and it is not that pharmacotherapy will work. So there should be an integration of intervention and pharmacotherapy. Third point is quality control and monitoring is very important. What you are doing, what your team is doing, what other hospital part is doing, whether nurses are trained or not, whether new residents are coming, they are trained or not. So what quality control is very important. Need to be a holistic pain physician. We teach in cancer pain. It is important to treat total pain, and we need to create a robust system, and we must teach young doctors and nurses basic cancer pain management and safe use of opioids. This is what we have done in AIMS, that we have integrated cancer pain management training in their undergraduate teaching curriculum as well as in nursing curriculum. So all these curriculum, they learn how to use opioids safely for cancer pain management, how to assess pain in cancer patients, otherwise how to assess pain. So we give a lot of emphasis, plus we give teaching on basic concepts of palliative care. So these are my final recommendation, and this is how we have created a system of safe use of opioids and robust cancer pain management in the hospital. Thank you very much. Thank you, Amitabh, for inviting me for this meeting.
Sushma, it's always a pleasure to hear your thoughts, and I think you bring up a very good point, that the care team, and not just the physician, but the nursing staff, the various other services that can help patients, not just with medication and interventions, but a holistic approach. That's something that, building that aspect of things is perhaps even more important than the intervention itself. Amin or anyone, does anyone have any specific questions that might be helpful to help you develop your programs?
Thank you very much, Dr. Sushma, for your intervention, and it may help us in Morocco, in North Africa, to start with the same idea. And I have some question for you, some technical question. You have a specific cancer pain center or just pain units? This is my first question. The second question, for example, for using neuromodulation, I'll start with opioid, with the pain management department consultation. But in how do you start neuromodulation in, for example, in your department? It was easy to start it, or it wasn't in the startup?
So thank you, Amin, for asking these questions. So the first question is that it is basically, I work in a cancer center of AIMS. All India Institute of Medical Sciences have a cancer separate building, so I work over there. So that's why I talk about cancer pain management. But the pain policy which we have created is for whole of the hospital. So the department of there are various pain resource team. For neuro patients, there is a pain resource team. For cardiac patients, there is a pain resource team. So this is what I have tried to create in whole of the hospital with the help of our administration. So cancer pain resource team will go and see the cancer pain patients, and if at all they will call in other building, if there is a cancer patient, they call us and we go there. This was the first question. And second question regarding neuromodulation. So in cancer pain management services, we integrate very holistically the intervention plus opioids. So neuromodulation also we are doing, but in 21 years, I analyzed the data almost of 13,000 patients of 10 years, 13,000 patients, but we have done only 20 patients neuromodulation. So this is what selection of the patient is very, very crucial. And because of most of the time, patients are not affordable, but even if they are affordable, I think selection of patients will be the crucial point to get the success. So we have done neuromodulation, but it is very less number because we are very selective in doing neuromodulation. Thank you very much.
Thank you. Thank you very much.
Do you have any other questions in the chat line or our colleagues?
There is one question that
There's one that says, how do we change the WHO pain ladder while we set up cancer pain services? That may be a tough one to answer.
I know, but WHO pain ladder, I think WHO pain ladder, WHO has given us a protocol, and I don't think that we have to just be worried that whether we have to change or not change. Every patient is different, and we have a very good, now we have a box of medication as well as intervention. So we have to decide ourselves based on the patient's requirement that what will work with my patient best. So I think we have to create our own protocol based on our available infrastructures and resources, rather than just running around that this should be there and that should be there. We have everything in our pain management intervention room, but it is not necessary that where I am creating this model everywhere. I always tell that whatever is available, please start, because your attitude is there. You want to treat your patients, and medications are very cheap. You can start, and then automatically once you will start proving, administration will support you, and all other medications, all other intervention procedures, equipments and everything will be available. Don't copy what is available in AIMS. So it is basically our attitude and our willpower that will make a difference, that what we want to do and what we want to create make a difference in the system.
Excellent point. Do you have a psychologist that works with you in your clinic?
Yes, definitely. Yeah.
Any other questions from our colleagues or faculty even?
I think one of the main things is just to educate other oncologists about what we are capable of. I think we've opened some satellite clinics, and one of the most helpful things that the oncologists find is our education to them as to what we can do from an interventional standpoint. So when you're talking about the WHO ladder, that can be altered, just like you said, based on the individual. And once the oncologists know what you're capable of, then it can be altered within the institution or the patient itself.
Yeah, that is very important point. I think there is a regular rotation of oncology residents in our department. So throughout the year, there are always 2 residents are there in our department. They just come to learn pain management. So I think this is very. Beside this, we do regular seminars once in a week, or grand rounds on cancer pain management. And now AIMS has given us a slot to give us 21 years of experience, that what we have done in cancer pain management and development of palliative medicine. So we are going to show them in February 2021 that how we have created a difference in India as well as in AIMS.
Thank you, Shrishma. I guess we have one last question that's really specific to India. Has the Indian government made or helped patients receive opioids for cancer pain, changed any aspect of this legally in the last few years?
Yes. So 2014 Amendment of Narcotic and Drugs and Psychotropic Substance Act clearly says that a person who wants to treat cancer pain patients, and they should be trained, and they can get it. It is now available. They don't have to follow the narcotin law which was there and they used to get 5 licenses. Even I used to get 5 licenses. It is not there. If I want to treat cancer pain patients, I just have to consult any pharmaceutical company, and we have to just the law now, the latest laws just say that you have to keep a good record keeping, that how many tablets you are procuring and how many you are dispensing to whom patient. So every patient's record is available, computerized record is available at AIMS, that how many tablets we have dispensed this to particular patient for 10 days, 15 days or for a month, and how many we have procured from a pharmaceutical company. So all the record keeping has to be very, very clear, and that's all. And then it is not a problem in these days. Only thing the problem is now, people still don't want to use. There are a lot of myths and misconceptions about opioids, and people don't want to use still. So that is, and lack of training and knowledge is also, as Grant says, that lack of training and knowledge amongst oncologists. So if we will start on morphine, they start thinking that, oh God, the patient will die and something like this. So we have to create a lot of awareness and improvement of knowledge.
Sushma, thank you very much for being a part of this. I really appreciate it. I think we all do appreciate your experience and all your contributions. Hopefully it's not too late in India, so you can get some sleep tonight. Any other final questions or comments? I mean, feel free, then we'll move on to our next presentation.
Thank you very much, Amitabh, and thank you, Amin, for inviting me, and such a wonderful gathering. And I think anywhere in cancer pain management meeting, I really would love to come and speak whatever experience we have. Enormous experience of struggle as well as success.
Thank you very much. Thank you very much, Dr. Sushma.
Thank you.
All right. Next, we have our good friend and colleague joining us from right on the other side of the water in Spain, from Morocco, Dr. Sifrian, who's going to really share with us his experiences for the use of various techniques for bone metastases. Many of these will be related to ablation and hopefully cementoplasties. We've had the fortune of being part of the team here at our institution with the spine tumor team and the bone metastases team. So it'd be wonderful to hear your thoughts, Manuel, on how a radiologist as well as a pain physician can intervene for these painful issues.
Thanks, Amit. Well, so the topic of the presentation is percutaneous procedures for bone metastases. Well, I'm interventional radiologist, as Amit was saying. I work in Hospital Universitario La Fe in Valencia.
Manuel, are you able to share your screen?
I thought it was sharing the screen. Sorry. Okay. Let me try again. I thought it was already being shared. Sorry about that. Okay. Is it shared now, Amit? Is the screen shared now?
Yes.
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 Oh, sorry. Thanks for your patience. So let's cross fingers. Okay. So well, I want to thank WAPMU and Dr. Gulati and also Ahmed, a good friend of mine, for the invitation, and also Dr. Amoretti that led me some material for this presentation. So the aim of the presentation is to define the actual indications and limits of percutaneous procedures in bone metastases. We will describe the guidelines and quality control in bone metastasis management, and also the necessary multidisciplinary approach in patient selection. So percutaneous treatment of bone tumors is a minimally invasive option compared with classical management. It has better recovery, lower cost, lower morbidity, mortality. There are many percutaneous techniques available, and it's important to know the anatomy, to plan the case, plan the entry point, the trajectory, and also to be familiar with the materials available and the image guidance available. All cases should be assessed in a multidisciplinary tumor board, in which there's usually an oncologist, radiation oncologist, orthopedic surgeon, radiologist, just to choose which is the better option for each case. So there are two main arms for treatment. On the one hand, we have stabilization, which includes vertebral augmentation, such as cementoplasty, kyphoplasty, stentoplasty, surgery. And the other arm is treatment, which includes ablation, radiotherapy, and systemic treatment. As interventional radiologists, we usually focus in vertebral augmentation and ablation techniques. The clinical presentation of the patients can be very different. So we have some patients without fracture that can be either symptomatic or asymptomatic. Some patients with fracture, it can be an unstable fracture or an unstable fracture. And in the worst case clinical presentation, they can have cord compression. So usually we use ablation for stable, uncomplicated cases. Vertebral augmentation can be performed in almost all cases, except when there's cord compression. Radiotherapy is usually indicated in all cases. And in my center, we reserve surgery for unstable and cord compression cases. So in some cases, we aim for a curative treatment, but in many cases, it's just a palliative treatment in which the goal is tumor reduction, pain treatment, prevention of complications such as pathological fractures, and in some cases, the compression of spinal tumors when there's extension into the epidural space. It's important to assess each case to see which is the clinical symptoms of the patient, to see the origin, location, intensity of the pain, to choose which is the best option. We usually vertebroplasty is used in patients with vertebral involvement, but without paravertebral invasion, and that have an associated risk of fracture. When there's paravertebral extension, we usually employ tumor ablation. That can be associated as well with vertebroplasty. So in the tumor management, we have curative options in which we include tumor ablation. Thermal ablation can be done with radiofrequency, cryoablation, microwave ablation, and we have palliative cases in which we have some cases we have need for consolidation, and we do cementoplasty. In some cases, there's no need for consolidation, and we opt for chemical or thermal ablation. And when there's need for tumor and size reduction, we opt for thermal ablation. The position of the patient should always facilitate the needle access in order to maximize comfort, both for the patient and for the operator. For lumbar and thoracic spine, usually the patient is in prone position. For cervical spine, our most common position is supine. And the preparation of the patient is the same for all spine interventions, with strict sterile conditions in which you have to prepare with care the entry point for the needle. When we're talking about extraspinal lesions, it's important to be aware of the anatomic compartments in order to avoid recurrence and also tumor seeding along the needle tract. So we should always try to plan the access so that uninvolved anatomic compartments are not crossed by the needle. Which image guidance should we choose? The main image guidance techniques available are fluoroscopy and CT. Fluoroscopy allows for direct image visualization of the needle, but has poor soft tissue contrast and a radiation exposure both for the patient and the operator. CT, on the other hand, allows for a very precise needle placement and can differentiate bone from surrounding soft tissues, neurovascular, visceral structures, but there can be some slight delay in the timing, and depending on your machine, it only allows for a single plane of imaging. We usually try to get both worlds to use dual guidance procedure in which we combine CT and fluoroscopic guidance. That can be done either with a combined CT or a CT plus a mobile C-arm. Usually we start with CT and we continue with fluoroscopy. There have been some recent advances in image guidance. There are different products available in the market. This is the one we use. It's called Imactis. And with this system, you place some markers in the skin of the patient, some detectors, and once you have done the CT, you can navigate with a probe similar to an ultrasound probe with several axis visualization, several planes visualization at the same time. So we can get a transverse, sagittal, coronal view and plan the entry point and see the needle trajectory until we reach our target. This way, we can reduce the radiation both for the patient and for us. We increase the accuracy, and it's sometimes easier to treat several lesions at the same time. Well, the material we use is the standard for all spinal interventions, and we also use the specific ablation material and vertebral augmentation material. We try to perform all our procedures with sedation, and only very selected cases we use general anesthesia. We feel safer when we have clinical feedback from the patient. So in our experience with use of local anesthesia and just sedation, you can perform most of the interventions and have a lower risk of complications as well. For the needle selection, you have to be aware of several criteria. First, whether the lesion is lytic or sclerotic. Also, the type of tissue involved, whether it's a bone or a soft tissue mass, the site of the lesion, and also your own personal preference. For lytic lesions, we use usually standard coaxial needles, 11 to 13 gauge. When there's mild ossification, we use bone biopsy needles like Osticut, and most of the time it's also a surgical hammer. And when there's dense ossification or a thick cortex surrounding the lesion, drilling can be necessary, and it's interesting to have some bone penetration set with a drilling device. This is one of the many biopsy sets available in the market. It's important to have coaxial systems that allow you to do during the same with the same approach, both biopsy, ablation, and cementoplasty. We usually start with a very thin needle. This is a 20 gauge needle that we use to start with the needle axis until we reach the periosteum. You can inject the periosteum with local anesthesia, and once we are in the right point, we remove the proximal part of the needle and use the Chiva needle as a wire, like a Kirchner wire. There are different sets in which some of them are already prepared to remove the proximal portion of the needle, and so make it easier to coaxially introduce a larger gauge needle. As we commented before, we find it important to have clinical feedback from the patient, especially when you're in sensitive locations near neurovascular structures, so that you can be aware if the patient feels pain or there's any sign of complication. So these kind of coaxial systems make it possible to do as many passes as necessary of biopsy, and also to complete the treatment with ablation or cementoplasty. For the lumbar level, the most commonly used approach is transpedicular, but extrapedicular approach is also possible. For the thoracic levels, we prefer to do extrapedicular approach. That's because the thoracic vertebral pedicles are often small and susceptible to fracture. And for the cervical level, we use an interlateral approach. And because of the higher density of neurovascular structures at the cervical level, we find it useful to combine the ultrasound with CT and fluoroscopic guidance. So we usually start with ultrasound to avoid hitting any sensitive structure, and then we change to CT and fluoroscopic guidance. In some cases that affect the upper cervical levels, like C1 or C2, it can be an option to do a transoral approach. In these cases, you require general anesthesia, and it's also possible for these lesions to do this approach. So the first technique we're going to talk is vertebral augmentation. These are the CIRSE guidelines on percutaneous vertebral augmentation that recommends vertebral augmentation for any painful vertebra with osteolysis due to malignant infiltration like metastasis, myeloma. But it's only palliative treatment and it has no anti-tumoral effect. So it should be used in conjunction with systemic treatment such as percutaneous treatment, thermal ablation. There has been a rapid evolution of vertebral augmentation in the last year. At the beginning was just vertebroplasty, then kyphoplasty was introduced, and in the last few years we have new devices like stentoplasty or vertebral body stenting. So with vertebroplasty, we aim for stabilization. Kyphoplasty or stentoplasty, we aim to create a space for the cement and to get not only stabilization, but also deformity correction. We have to be aware that we can only provide anterior stabilization, and if the case requires posterior stabilization, it should be done by surgery. So vertebroplasty is the percutaneous injection of cement for the treatment of painful vertebrae in order to provide relief pain and provide stability. It can be done for almost any painful vertebral lesion. And we're talking today about painful vertebral metastasis. But as we were saying, it could be done in any painful lesion. Here we have a case of invasive hemangioma on T11. And this is an extrapedicular approach. And this case was done with CT fluoroscopy. And we can see how accurately we can distribute the cement in the vertebral body and also in the posterior elements, in the pedicles. So with proper image guidance and good material, it is very safe and there is a low risk of semen leakage. Here on the left side of the screen, we have a patient with metastatic bladder cancer and a painful spinal metastasis and on L5. This was an transiliar transpedicular approach with vertebroplasty and pain relief for the patient. At the beginning, it was common to do phlebography in many cases, in which we injected contrast to try to predict which would be the distribution of the cement. This is rarely done right now, and in our experience, is not necessary in most of the cases. There are many different variants of cementoplasty. This one is called vesselplasty. In this technique, instead of using a balloon, like in kyphoplasty, we use a container that is filled with cement, and it's only perforated on the anterior aspect. And this way you get a distribution of the cement in the vertebral body without risk of leakage into the posterior elements of the vertebra. The other main technique for vertebral augmentation is kyphoplasty. It's a modification of vertebroplasty in which, as we were saying, we not only aim for pain relief, but also for the additional goal of restoring vertebral height using balloons. We do first the approach with a beveled needle that we insert into the vertebral body. Then we insert a trocar all the way into the anterior third of the vertebral body in order to create a space for the balloon. Once we have created a space, we introduce the balloon, we inflate the balloon, and after deflating the balloon, we inject the cement in the cavity created. This way we reduce the risk of semen leakage and also try to restore the height of the vertebra. Here we have an L2 vertebroplasty. Most of the cases is bilateral, but it can be done unilateral depending on the case. There have been many evolutions, and we have some alternatives to kyphoplasty. We have kyphoplasty, stentoplasty, spine jack, radiofrequency kyphoplasty. All of them aim to reduce the risk of semen leakage and also to prevent secondary vertebral height loss. This is an example of radiofrequency kyphoplasty. It's the image on the left side of the screen. in which through the combination of ultra high viscosity cement and radiofrequency, you get an increased height restoration and also a better distribution of the cement. Another of the techniques is the spine jack. There are different sizes depending on the level and the lesion you want to treat. You always have to place 2 implants on both sides of the vertebra, and you place them just under the vertebral plateau. So we have them here under the end plates, and once they are in place, you can modulate and open them as much as you want. So this way you can restore height with much better control than with kyphoplasty. With kyphoplasty, you just inflate the balloon, but you cannot modulate how much you want the end plate to move. So here, once you are satisfied with the position of the spine jack, you introduce cement. And in most of the cases, like this one, you get a much better restoration of vertebral height. Although most of our cases are for spinal meds, it's also common to treat other locations, like when there's pain for metastasis in the femoral head, femoral neck. Many of these cases are treated with cementoplasty, not only for pain control, but also to prevent risk of fracture. It can be done just with cementoplasty, or like in this case, this is a percutaneous implant that you can place along the axis of the femoral head and neck. And after placing the implant, you release the cement inside. The other group of techniques are ablation techniques. Most of the techniques are thermal ablation techniques, but in some cases we use chemical ablation techniques. This is a case of invasive hemangioma. We saw in a previous picture an invasive hemangioma that was contained within the vertebral body. When we have a complex invasive hemangioma like this one, in which we have bone affection, but also an invasion of the epidural canal and cord compression. So what do we do in these cases? This is a percutaneous injection of contrast into the bone, into the transverse process. We do a phlebography with CT, and here we can see how the contrast invades also the epidural space and all the bony component of the lesion. And with the same approach and just a 20 gauge needle, we can treat the tumor. We usually use disco gel, that is a jellified alcohol, and in most of the cases you get very good clinical results with just one treatment. But for most of the cases, we will use thermal ablation. The main tool we have is radiofrequency ablation, in which we usually aim to have control of the disease progression. We can treat pain. It can be employed also for radiation-resistant tumors, for expansive metastases, oligometastases. It can be combined with radiotherapy. And it's important that all these cases that we were saying should be evaluated in the multidisciplinary board. One of the advantages of radiofrequency ablation is that you have a very precise control of the ablation zone. You have to choose your material, the active tip, the gauge of the needle, because depending on your choice, you will do a larger or smaller lesion. There is always risk of thermal injury to adjacent structures. And in this case, bone is your friend. When you have a cortical bone of at least 5 millimeters, you usually get thermal insulation for the treatment. There is greater risk when there is a rupture of the cortical bone. And in those cases, it can be useful to use a thermocouple for temperature monitoring. It can be monopolar radiofrequency or bipolar radiofrequency, which we have larger ablation areas, faster and more predictable. So radiofrequency has been used for a long time. This is an osteoidiostoma, and right now I think it's always treated with radiofrequency, another osteoidiostoma. And so with CT guidance, you can get very accurate positioning of the needle in a very small lesion and successfully treat it. In the same way we do it for benign lesions, we can do it for metastasis. This is a patient with lytic metastasis at L3. And this was done with cone beam CT, in which we combine fluoroscopy with CT reconstruction. This is the RF probe. And with the same access, we do radiofrequency ablation and then vertebroplasty. There have been new advances with radiofrequency, for example, flexible electrodes, specific radiofrequency bone algorithms, cool bipolar RF, and so we have more and more tools available for treating our cases that allow us for a very precise control of the ablation area and also to combine it with cementoplasty during the same procedure. This is a case of a metastatic paraganglioma in a cervical vertebra, which is a very small lytic lesion. And as we say, in these cases, we always combine with ultrasound just to avoid hitting any sensitive structures. And once you're in place, we did a combination of radiofrequency and also vertebroplasty. In our experience, you don't require usually a large amount of cement. With just a very small volume, it's usually enough to get stabilization and pain control. Another paraganglioma case, this is a metastatic paraganglioma on C2 in a 12-year-old patient. And we also combine ultrasound, CT, and fluoroscopic guidance. This is the radiofrequency probe. And we combined ablation with cementoplasty. Most of our cases are spinal cases, but it can be done in other locations as well. This is another paraganglioma. We treat a lot of those because they are patients with very good prognosis, but sooner or later they always get local invasion, and that's usually when in the tumor board we decide when and which lesion should we treat. This is a sternal metastasis, very painful. The patient was in bed with VAS score 10 out of 10. And so we combine in this case as well radiofrequency ablation. We did 3 approaches with cementoplasty. And these cases are very satisfactory because usually the pain gets pain relief immediately after the procedure. In our center, we usually ask the patient to stay in the hospital 24 hours, but they are systematically discharged the day after the procedure with almost no pain. Another of the techniques available is microwave ablation. Microwave ablation has some advantages in selected cases because it allows you to modulate the lesion, the size of the lesion. Depending on the parameters of the microwave ablation, you can make larger or smaller lesions. So this case had several lytic lung metastases. And here we see there's a rupture of the posterior wall. It was painful. And there was epidural involvement. And so we opted for an extrapedicular approach. And with microwave ablation, we can measure exactly which is the distance to the epidural space and increase or decrease the size of the ablation. And it was combined with vertebroplasty as well. Also, in some cases, we aim not just to try to treat pain, but also to avoid complications, such as when there's risk of acetabular or pelvic fractures. Here we have an acetabular lytic lesion, CT-guided approach, and with vival needles, we usually can navigate very precisely, reach the target. And this case was also microwave ablation combined with cementoplasty. We see the distribution of the cement on the lytic lesion. And as we said, we usually don't aim to put large amount of cement, just enough to fill in the cavity. Last, we have cryoablation. Cryoablation uses different gases. It can use argon or helium. Cell death temperature ranges between -20 to -40 degrees. And it has some advantages, like the possibility to use multiple probes simultaneously. Another of the advantages of cryo is that you can pick different probes and so choose which shape and which size you want for the treatment. They are almost always used with CT, but you can use ultrasound as well. You visualize the ice ball, so you have visual feedback of the lesion. It's the only ablative technique that allows you to have visual feedback. You don't have that with microwave ablation. You don't have with radiofrequency. Another advantage is that you have less post-procedure pain, and that is also effective in sclerotic bone metastasis. It has some disadvantages though. It has higher cost. It takes longer. There is also risk of nerve injury, and it's harder to combine with cementoplasty. You have to wait for the resolution of the S-valve or complete the treatment in a second time. Just some cases of cryo. This is an osteoblastoma that was treated with embolization and then completed with ablation. We see the two cryo probes. And in this case, we use a combination of carbon dioxide dissection and thermocouple to monitor temperature. Another case, this is a relapse of sacral chordoma on MRI and on CT. He had previous surgery, previous radiotherapy, and this was performed with this IMACTI system we were talking about that allows you to see the needle progression in several planes. So we opted for an approach through the sacral hiatus. We can see the needle on sagittal view, transverse view. So very accurate placement of the needle for cryo with the system. It can be, just to show some interesting cases, we use it a lot for bone, but it can also be used for soft tissue masses. This is an S1 schwannoma that is close to the piriformis muscle and is producing radicular pain for the patient. We place a cryoprobe, thermocouple, and here in this last picture, you can see the ice ball. As we were saying, the only ablation technique that gives you visual feedback of the lesion is cryo. So it can be interesting because if you don't treat the lesion completely, you can, during the same procedure, complete and place another cryo probe and complete the treatment. This is the ice ball with 3D CT reconstruction. Another example of cryo, this is a skeletal chondrosarcoma. It had previous surgery, radiotherapy, radicular pain. We had done injections. We had done embolization of the tumor. And so finally we did cryo, 2 probes, thermocouple, also to avoid hitting neurovascular structures, and the cryoablation that we can see the ice ball covering the whole lesion. So to conclude, we have multiple effective techniques for percutaneous treatment of bone metastases, both for stabilization and for tumor ablation. It is possible to combine them with all the other options like radiotherapy, both before, during, or after radiotherapy. It has low morbidity, low mortality. We have to think both about stabilization and treatment. There are many tools available. We have to be aware of them. We have to understand the indication of each technique. And I think it's crucial to evaluate every case in the multidisciplinary broad to choose the best option for each case. Thank you very much.
Thank you, Manuel. That was a wonderful presentation on some really advanced techniques. I'm sure we have lots of questions coming from our audience and colleagues. I suppose I have one question just before we move on, is how do you propose, some of these techniques are so technically advanced, how do you propose someone that they may not have access to someone as specialized as you to learn some of these things and have an opportunity to provide some of these techniques for their patients? And if they could learn something, what would be the one thing you would teach first?
Well, I think there's a learning curve for all these techniques, and usually you have to start with simple techniques like bone biopsy. It can seem like basic, but if you can do a bone biopsy properly, you can probably do any kind of ablation technique as well. I think it's also important to start with easy cases, and possibly with support in our center. Some colleagues come and it's possible to come, and also we have fellows to learn and but probably you have to go step by step. Start with biopsy, then go to vertebroplasty, and then ablation, and probably cryo and some techniques are not even necessary in many centers, and most of the cases can be treated with RF ablation and cementoplasty successfully.
Thank you. Yes, it seems very complex to learn some of these things. Any questions from your end?
Thank you, Manuel, for this wonderful lecture. And I have one question for cryoablation. Do you use it for all your? What do you prefer, cryoablation or radiofrequency for your bone metastasis?
Well, cryoablation is more cumbersome, it's more expensive, it takes longer. So we use it for selected cases. When would I prefer a cryo? When there's, for example, a epidural involvement and there's risk of hitting neural structures, I think it's a great help to be able to visualize the ablation. But for most of vertebral mets, I think they can be treated in our center. 95% of them, we treat them with radiofrequency or microwave ablation. And I also like to combine a lot with vertebroplasty. And so I usually limit cryo for lesions who are very close to neural structures or sclerotic lesions that cannot be treated successfully with RF.
Okay.
Any questions from any other colleagues?
Yes, I have one, Amit. Thank you.
Go ahead.
It's any advice for extraspinal disease to avoid neural damage besides the awakened patient? We usually sedate them because they don't tolerate the biopsy or the augmentation. It hurts.
So, usually I never use general anesthesia. I prefer to have conscious sedation and local anesthesia. And I feel very comfortable when there's feedback from the patient. Also, when there's risk or I feel there might be compromise of a neural structure, I think it's safe to place a thermocouple nearby in between the sensitive structure and the ablation target, just to get advanced. An advanced call before damaging any lesion. But for me, I think it's important to have good material, good image guidance. Sometimes, for example, for cement leakage, I think if you have good cement and you have a good image guidance, I think it's almost impossible to have significant leakage. But probably you should combine all possible help: conscious sedation, good image guidance, good material, and thermocouple help when in sensitive cases.
Thank you.
Excellent. It's wonderful to see your wonderful techniques in this field, and hopefully we get to learn some more of these ideas going forward. We definitely see our radiologists at our institution using some of these very similar techniques and similar discussions of when to appropriately use cryotherapy versus radiofrequency, cementoplasty, and along with surgical resections and radiation.
Thank you.
Thank you.
All right, everyone. I know it's becoming a little bit long time, but hopefully we will catch up in the next few minutes. Next, we have Dr. Grant Chen, who's not only my colleague but dear friend, who has done a lot of a wonderful and great work on intrathecal drug delivery, especially with some algorithmic decision making. He's contributing a lot in this field, and I hope that he'll have some valuable information for our colleagues on this conference. So without further ado, Dr. Chen will give you some moments on the topic of intrathecal drug delivery.
All right, thank you everyone for having me. Can everyone see my screen?
Yes.
Yes.
Okay. So before we talk about updates, we should talk about history. So what you see here are two very prominent physicians who helped develop intrathecal anesthesia. You have August Beer, who in 1899 injected cocaine into his spinal fluid. Once he did that, him and his assistant tested the pain sensation by stabbing a needle into his femur, pulling on pubic hair, and also using a hammer to his shin, and he felt no pain. So they realized that local anesthetic can really help with pain control. And then you had Rudolf Mattes, who in 1900 mixed morphine with cocaine to help mitigate some of the side effects from the cocaine. Then Joseph Wang looked at 8 patients with GU malignancy, genital urinary malignancies, and metastasis to the lumbosacral plexus. And these are patients who also failed systemic narcotics. He injected morphine over the course of 24 to 48 hours, and you can see that their pain scores on the left have really decreased after these injections. Then Dr. Yax and Onofrio implanted intrathecal opioid delivery device as the first implantable device to help with intractable malignant pain. Afterwards, in the beginning to 2000s, you started having many people implant intrathecal pumps to help patients with cancer. And there are many publications here that look mostly at opioid or a combination of opioid and bupivacaine for the treatment of cancer-related pain. Here you have the first, you have a demonstration of a decrease in pain scores. The first one is from Brogan and Winter in 2011. It was a mixture of opioid and bupivacaine. Some patients also had clonidine, and the bupivacaine was a pretty wide range. It ranged anywhere from 0.5 to 23 milligrams per day. And the morphine was also very wide range. It's 0.2 to 100 milligrams per day. Now, the second one, they basically asked the patients for the pain scores after 4 weeks. And you can see that the pain scores have decreased significantly. Now, on the second graph, you'll see that the improvement of pain after an intrathecal pump was implanted was significantly more than CMM meaning conventional medical management. So this is the study done by Burrell and Burton that shows a improvement in pain scores after implantation of intrathecal pump. This article was published in 2020, this year, and this shows the decrease in pain scores. So this shows a decrease in pain scores also after implantation of intrathecal pump, and we followed it for up to 6 months. The way this was done, the author looked at the historical data spanning 15 years, came up with a formula, and placed the subsequent patients on this formula. At the 1, 3, and 6 month follow-up, the pain scores were recorded, and you can see that the pain scores decreased by 50% pretty consistently. Here is, so not only does the pain score go down, but there's also an obvious reduction in opioid use. The first one showed that nearly 50% had a 100% reduction in non-intrathecal opioid use. And the second chart shows the consistent, sustained non-intrathecal opioid use decrease following implantation of a pump. This is the fact that it's consistent is important because this means they don't necessarily experience the side effects that comes with oral opioids, and also the tolerance with oral opioids does not build up as quickly. Now, catheter location is very important. The catheter location in the cervical, thoracic, and lumbar spine is paramount to ensure that the intrathecal medication helps the patient. Part of the reason is you want the medication, part of the reason is that the medication in the intrathecal space does not travel very far from where it's deposited. So these two studies are by Bernard and Flack. It shows that the medications stay in the area. On the left, you'll see that there's a steep decline in the morphine concentration as the distance from the source increases. And then on the right side, you'll see that where the blue part is, that's where the catheter tip was located. And you'll see that the methylene blue stain stayed only at the posterior portion of the spinal cord. This means that the fluid in the medication doesn't travel very far from where the tip is. That's why it's very critical where you place the catheter for the intrathecal pump. So at Sloan Kettering, this is where we place our catheter depending on where the location of the pain is. So for brachial plexus in the arm, we place it in the cervical spine. For the breast, it's in the upper chest wall, it's in the upper thoracic spine. And then anything in the abdominal wall, we put it around T5 to T7. Pelvic pain would be lower thoracic, leg pain, lower thoracic, and anything in the sacrum, for example, rectal pain. Actually, most of it is rectal pain. We would place the catheter at the conus. So another question we often have is, do we trial with an epidural trial, or do we just go ahead and place the pump? At our institution, we don't do an epidural trial because there's several studies that show it's not really necessary for cancer-related pain. The patients often have advanced disease and limited survival time. So to place an epidural trial for an intrathecal pump really is just costing the patient time. So the part of this kind of talks about why we don't place trial. It minimizes the delays in achieving satisfactory analgesia. There's an earlier discharge home time, and also it's a decrease in overall cost when you don't necessarily use a trial. So if you don't use a trial, how do you dose the opioids? There's a study done in anesthesia and analgesia in 2013 that that calculates what post intrathecal morphine equivalent should be necessary. For our purposes, we typically just do a 300-to-1 or a 100-to-1 oral morphine to intrathecal ratio, depending on whether they're opioid naive or opioid tolerant. So patients who've been on opioids for a very extended period of time, we use a 100-to-1 opioid morphine ratio. Now, the bupivacaine dosing, we've looked at data from several years back and see what patients are comfortable on and what patients were discharged on. And we've decided to come to a conclusion where the bupivacaine dose, initial bupivacaine dose, should be based on your catheter tip level. So for cervical spine, we started at 5 milligrams per day. And then for everything else, we start at 8 milligrams per day, other than T5 to T8. T5 to T8, we started at 10 milligrams per day because the higher dosing of initial bupivacaine will not cause as much side effects. In terms of side effects, out of 43 patients, 7 experienced side effects. 3 had urinary retention and 4 had lower extremity numbness. However, even with the numbness or urinary retention, 2 of the patients continued on the same bupivacaine dose because it really helped their pain. Next, I want to talk about intrathecal clonidine. So Eisenach randomized 85 cancer patients to receive epidural clonidine for severe pain not controlled by opioids. What he found was it really helps with neuropathic pain. The problem is clonidine also had significant side effects, such as peripheral edema, and it can also cause sedation in a dose-dependent fashion. At low doses, clonidine can cause hypotension, but oddly enough, at higher doses, it can cause hypertension. There's another study that looked at intrathecal clonidine, and they found that it was very successful. Now, when you look at the Kaplan-Meier curve, it only shows around 40% success. However, that is pretty significant because these are patients who they've already had trouble controlling their pain with with oral opioids or other methods. So the PACC guidelines or recommendations for starting dose of clonidine is 40 to 100 micrograms a day. Again, this is a starting dose. Some people start much higher and some people start much lower depending on sedation effects. So at Sloan Kettering, we start our patients at 50 micrograms a day if their pain also has a neuropathic component to it. Okay, let's talk about intrathecal ziconotide. It's an N-type calcium channel antagonist from the cone snail. So there has been several papers written on intrathecal ziconotide, and it definitely helps with pain. However, there are some issues, especially when you're looking at cancer pain. There's some limited tolerability. As you can see on the left side, there are several side effects. Also, it's a very slow titration scale. And given the limited lifespan of some cancer patients, you might not want to use ziconotide and its slow titration scale. There's a narrow therapeutic window. The one benefit of ziconotide is that there is no such thing as building tolerance to ziconotide. So in this paper, they looked at starting dose of approximately 2.4 micrograms a day. And as you can see, the increase of ziconotide is very slow. They increased it by less than 2.4 micrograms a day every 2 to 4 days to a maximum dose of 19.2 micrograms per day. And some also recommend an even slower titration rate of less than 0.5 micrograms per day every week. So again, this can be an issue in patients with pain, cancer pain. Another study showed that if you do a bolus dosing of ziconotide, it may help compared to a continuous dosing of ziconotide. And this was shown in the article from Neuromodulation 2016. Lastly, there's a recent study that showed a triple intrathecal combination for end-stage cancer. This is a study that looked at 0 to 56 days, and they started with the morphine oral to intrathecal ratio of 400 to 1. They started with a levobupivacaine dose of 3 milligrams per day. And they also added ziconotide starting dose of 1.2 micrograms per day, and they increased it at 1.2 micrograms per day at a interval of 7 days. And what they found was that VAS scores decreased by more than 50% at 56 days. So in conclusion, there's several different combination of medication that you can use for intrathecal pain control in cancer patients. You have to figure out what you want, what you're comfortable with. What we've developed at our institution is a very standardized protocol of morphine, bupivacaine, possibly clonidine, and we also think about ziconotide if that will help our patients. Thank you.
Thank you very much, Dr. Chen, or Grant. It was a wonderful discussion on some of the complex algorithms we can use to help our cancer pain patients using intrathecal drug delivery. I don't see any questions in the chat or the Q&A, but do some of our faculty or other members have any questions they might want to chime in? I know Dr. Kiwan is shaking his head.
I have a question. It was really a really great talk. I really enjoyed it. I actually took a couple of screenshots, if you don't mind.
Yeah.
I have a question here. So, in terms of ideal catheter position, your neuromodulation, that neuromodulation citation is really interesting for various pain conditions that the tip needs to be located at the different side. To your experience, does it matter for more of a kind of a hydrophilic drugs? It doesn't matter that much or not. For Dilaudid, for example, for morphine example, I'm sure for fentanyl or bupivacaine, clonidine, those highly lipophilic drugs, the location of the tip will give us a different kind of outcome. That is my first question. My second question is, have you had any experience utilizing intrathecal ketamine, and what is your perspective on that? Thank you.
Sure. So for your first question, we typically start with morphine. So we place the catheter tip at the location where we think will help most with morphine. Now, if morphine doesn't help, or if a patient have problems with the side effects of morphine, then we consider switching to hydromorphone and then switching to fentanyl. By then, the tip was already located at the location of where we put our catheter tip. The reason it's important is you also have bupivacaine. You can have clonidine. The starting dose of the medications don't necessarily mean that's what you'll stick with. So it's really important to because you never go back in to revise the tip.
Right.
So it's important to the first try, you should try to place that tip at the location you want, and then you can play around with the medication. In terms of your second question, your intrathecal ketamine, I have not had any experience. I don't know if Dr. Galati has any experience with intrathecal ketamine.
We haven't used intrathecal ketamine. I know Michael Ashburn in UPenn has done a few cases for end of life. There's always some concern from old rabbit studies showing some ulcer formations on the spinal cord. But probably for end of life, I know one of my mentors, a late great Lisa Stearns, she used quite a bit of ketamine in her pump delivery in her system, and there's some literature using low dose ketamine. So I think in end of life cases, ketamine is a reasonable option. We don't have any evidence in the swine model or any human models about any damage related to ketamine in the intrathecal space to the spinal cord. But we do have some colleagues that have used it. To piggyback on some of your first question that Grant answered, we do think of morphine and fentanyl as more hydrophilic and more concentrated at the location of the catheter tip, as opposed to fentanyl and sufentanil, which tend to have more dosing, more closely related to epidural and intravenous dosing regimens. So if you work with your pharmacist who compound your medications, they will both tell you your pKa, your lipophilicity, your weight or your Daltons of your drug, and your whether it's an ionic or like a protein such as ziconotide, and they can probably predict its diffusion or dispersion through the CSF. And so I tend to think of fentanyl, sufentanil, ziconotide as your catheter independent medications. Perhaps clonidine may fit in that, but the morphine and the hydromorphine, which is even a little less hydrophilic, so they tend to concentrate at the catheter tip because of the lack of flow of the CSF, especially the lumbar spine and the low thoracic spine. You might see some flow patterns that are different in the cervical spine, especially from our Arnold Chiari data. So that may actually see more circulation in higher catheter raises. That's primarily because the spinal cord is bigger. The vessels attaching to the spinal cord are pulsating a little bit stronger, and there's less space in between the CSF, the spinal cord and the wall itself of the dura. So and then we think of it that way at least.
So in any case, you would highly recommend that we position the tip at the most ideal locations from get-go.
Correct, and
regardless of drug choice,
and on the posterior side as well.
Yeah.
Our 4 incidences of hyperalgesia are all anterior catheters or lateral catheters next to the anterior rootlets of opioid hyperalgesia. So I think catheter position will tell you what drugs to use, and you should choose your drug based on your catheter position. They're almost like chicken egg. Like if you can't get your catheter high, you may not choose morphine. You may choose fentanyl. You might choose ziconotide as opposed to bupivacaine. You might alter your drug choice if you need to get to the cervical spine. Your catheter got stuck at L1 or T10 or whatever.
Yeah.
We have one question from the chat line. Is the procedure done under fluoroscopic guidance? What's your preferred entry level of the catheter insertion?
So the procedure is done under fluoroscopic guidance, and we prefer entering below the conus. So typically at L1, it's just safer that way. I have colleagues who do enter in the thoracic space if they are trying to thread the catheter up to the cervical spine, and there's some possibility of hindrance lower down. But typically, we prefer entering at L1 and guiding the catheter up using fluoroscopic guidance.
I have one question. Thank you, Dr. Grant Shen, for this great lecture. It was very, very great. And my question is about the indication of using intrathecal drug. In our practice, we have this problem with the indication when we can't use or you can't implant the intrathecal drugs for the patient, for example, with survive under 6 months or less, or we have there is a lot of manuscripts about the indication, but I don't know in your practice how do you assess, how do you indicate for this patient, for example?
That's a very good question. In fact, we prefer putting in the pumps earlier than later. So first of all, if we anticipate that the cancer will continue to grow or the pain will get worse, or the opioid requirements will escalate fairly quickly, we prefer to put in intrathecal pump earlier than later. And that's what we've been trying to convince the oncologist to to refer their patients to us sooner for evaluation of these pumps. Now in terms of later stages of cancer, it really depends. So obviously, longer period of life patients can benefit from the pump more, and there's a cost effectiveness of it. Some studies have shown that cost effectiveness of a pump is for patients who have a life expectancy of greater than 3 months. Now, if a patient only has 1 month left, 2 months left, should they get the pump? That's questionable, and on a month-to-month, on a patient-to-patient basis, we are typically a little more aggressive in treating these because some patients, even with the 2 months left and having these pump, can benefit from the side effects of not taking the oral opioids. So it's hard to say. I wouldn't put a specific time stamp on it, but I would take it patient to patient.
Okay, thank you. Thank you very much.
Thank you, Dr. Chen. Not seeing any questions, and I know we're getting to the tail end of this conference, so thank you. This leaves us with 2 presentations left. I will give only a few-minute talk on neuromodulation and cancer pain so that we can give Dr. Kwan more of a chance to talk about his interventions for head and neck cancer. And also, I don't want to hear myself very much, so I want to hear other people talk. So I'm just going to share my screen and talk about how some of these neuromodulation techniques are coming into oncologic pain management, and we will then answer any questions related to that. Let me just take a moment to share my screen. So just a couple of brief discussion points on how we've kind of transitioned in using electrical stimulation at our institution, really since my career started now, I guess, 14 or 15 years ago. And really wanted to focus on transcutaneous electrical nerve stimulation for a few slides. And kind of our initial work on this for the first 5 or 6 years of my career. Transition to peripheral nerve stimulation, which really is in its infancy or its baby steps right now. And then spinal cord stimulation. First, just briefly on the evidence and how we use this and some of the important points that come up with spinal cord stimulation. These are my financial disclosures. We all learn the same way. We can modulate the pain signal a myriad of ways. Dr. Chen did a wonderful job explaining how we can turn on the inhibitory neurons of a second-order neuron that's projecting pain, shown here with the C fiber, using the morphine receptor or targeting the mu receptor with morphine. But we can do this electrically as well. So we can stimulate the sensory fibers or the motor fibers. And that also has an indirect effect in turning off the pain fibers shown here. I'm very simplifying all of this. There definitely is much more complexity to this system, both chemically, but we can modulate this by activation of the sensory or motor fibers. So with that in mind, there's been some evidence in the literature of using transcutaneous electrical nerve stimulation for patients. These are some of the older studies for breast cancer patients who are having chronic pain related to their treatment. So post-mastectomy pain syndrome, something we talked about with Dr. Lucas earlier. And just looking at the data that says this, there's some efficacy compared to placebo when you use TENS units. This is repetitively done again in Leeds in the United Kingdom. Again, this is a case series of using patients who are suffering from bone cancer, and an hour session, and then patients after 1 hour had reasonably good pain relief. Again, the time of improvement may be 1 or 10 millimeters or 1 centimeter on a VAS scale. And then this is our data. So we started using TENS units very early on in when I started my career, and initially what happened, I noticed, was when we would send patients for TENS units to a physical therapist, which was a convention in the United States, either a physical therapist would not deliver the electrical stimulation, which I'll talk about in a few minutes why, or the patient would come back and tell us that the TENS unit was not helpful. And what we found was that when we looked at our own patients and we started doing our own TENS unit trial. So a patient would come into our clinic, we would apply the TENS unit for their painful area, and this is the various kind of cancers we were treating. And what we would notice was that in general, when we educated a patient how to use a TENS unit, we saw some reasonable improvement in their VAS scores. But perhaps the most improvement that we saw was not necessarily their pain score, but that the activity level significantly improved. So for example, patients who had sarcomas of their sacrum, had radiation and or surgery and had a lot of pain in this location, we would apply a TENS unit shown here, and we would ask them to either walk or to stand and do their dishes, which is a common complaint in the New York area, was to walk a block. And we would see if they could walk further or stand longer with the TENS unit on. And that's where the improvement occurred. So patients were able to improve their function or their goal, but their pain score stayed the same. And so we changed the way we taught TENS units to be more as a goal-directed therapy as opposed to a pain-relieving therapy. And we saw greater acceptance of the device as a result. So now looking at the current data, we have some reasonable data from our head and neck cancer patient population. This is from a group that published in 2018-19 from data from 2012, 2013, using the technique of using TENS 3 days a week for patients who are undergoing radiation, 6 weeks of treatment for their tumor and their head and neck area. And then for the second half of their radiation, where the skin lesions, all those kind of things become more painful, where they targeted the temporomandibular joint and the neck, cervical neck, with small pads, and they used 125 hertz and 100 microseconds for the pulse width. And they saw some reasonable improvement in pain for resting. However, they did not see improvement of pain for their actual functions, the opening and closing of the jaw, for example. So the resting pain significantly improved. The other things did not improve as much. So the real question became, well, how do we choose our settings in this population? One of the concerns that our physical therapists have always had is that the electrical stimulation of the area may activate and lead into metastases. One of the concerns is that using a TENS unit may increase blood flow. We know this, especially with muscle contractures, but TENS units, so low frequency TENS, 2 hertz, 10 hertz, 15 or 20 hertz, may activate a muscle, and that activity of a muscle may increase blood flow. Therefore, it may increase the spread of tumors indirectly, while there's obviously more complexity to metastases and attachment metastases. Nonetheless, there is a concern in the literature. There is some evidence in electroacupuncture that actually improves immune function and wound healing in the animal model. But perhaps the most important thing was in their own literature in physical therapy, higher frequencies, such as above 80 hertz, so 100 hertz, 120 hertz, which is sensory stimulation, did not seem to have an impact in muscle contraction, and therefore also an impact in blood flow. So from a perspective of oncology and physical therapy, it tends to be that higher frequencies, 100 hertz, 80 hertz, 150 hertz, tends to be more accepted than lower frequency contractions, primarily because of the theoretical issues that may arise from muscle contractures and increased blood flow. This is not to say that there's any evidence that TENS units do actually increase metastatic disease or tumor burden. There is some conflicting evidence in the animal literature, but nonetheless, in the clinical literature, this is not necessarily the case. So one of the newer devices that has really happened to be taking have been very helpful for our pain patients, at least in the United States and probably in Europe, is peripheral nerve stimulation. So the idea of bypassing the skin, which is a resistor, and therefore requires a lot of current to overcome and send a current beyond underneath the skin. One way to do this is to pierce the skin and place a lead or contact underneath the dermal layer next to a nerve and start stimulation. And as a result of bypassing the skin, you can have smaller electrical fields, and therefore smaller amperage to drive the voltage needed to generate a field that would activate a neuron. So from the idea of peripheral nerve stimulation comes the fact that there may be ways to differentiate your sensory fibers that are firing. So there may be some variables that are applicable, such that the A beta fast-acting fibers, the more pleasurable sensory fibers, can be preferentially activated as opposed to the slow activating fibers or the A delta fibers, which are more painful, send the more painful signals. Because there are some variables that might allow peripheral nerve stimulation to achieve this, this is one of the advantages of peripheral nerve stimulation over transcutaneous electrical nerve stimulation. This is the specificity to activate different fibers of a nerve. Some of this data comes from our colleagues at Wake Forest. Rick Rauch and his colleagues in Winston-Salem initially targeted patients who had post-amputation related pain. These are 2-week trials, and patients who had significant improvement in their pain relief after stimulating both their sciatic and or their femoral nerve. And this pain relief was prolonged even though the stimulation was discontinued. So you would have 2 weeks of stimulation, you would see a significant drop of both phantom limb pain and residual limb pain. Again, this is a small case series of patients. And over 2 weeks, that pain relief sustained. But as you discontinued the device, you saw not a complete resolution of the effect of the stimulation, but in fact, there was some decrease in pain even afterwards. We do have some data that's newer in the phantom limb population that suggests that longer stimulation may lead to longer pain relief in a certain subset of patients. So that is definitely being shown in the literature thus far. But what we really found out was that the lead itself did not necessarily need to be next to the sciatic nerve, but it could be a small distance away from that nerve. And this study suggested that distance away from nerve and narrowing the pulse width may actually allow you to activate those A beta fast-acting fibers from a sensory stimulation perspective, have a much more pleasurable sensation that activates the gate theory, so you don't necessarily interpret the pain signals. Some of the neuromodulation data from computer modeling supports this idea. So computer modeling data really suggests that at 1 centimeter, 10 millimeters, or 15 centimeters or 15 millimeters, when you start activating your electrical contacts, there are some preferential variables that will allow you to activate your A beta fibers prior to activating your A delta fibers. So it seems like if you're too close to a nerve, if you give a little bit of a field, everything activates. If you're too far from a field, then you have to give enough of energy to activate a large field, and there's very difficult ways to differentiate your A beta and your A delta fibers. But around 1 to 1.5 centimeters, when you turn on a field, there may be just enough energy given at a short pulse width, we're talking 10 microseconds, 15 microseconds, that may activate your A beta fibers, but not your A delta fibers. There is some animal data now that we have suggesting that higher frequencies, in this case 120 hertz and 60 hertz at low milliamplitude, in the animal model suggests that there is actually second order neuron changes that are occurring in the connection for descending inhibitory neurons as well as the ascending spinal thalamic area neurons. This is in the animal model, suggesting that a surrogate gene expression of the use of the glutamate receptor is decreasing over time with higher frequency stimulation of the sciatic nerve. That's basically the sciatic or tibial nerve that is the surrogate for the mammary gland tumor model in Sprague-Dowley rats. And so with this idea in mind, we felt that there was a population in our group that may actually benefit from the use of peripheral nerve stimulators in active cancer pain. So these are some patients. Really, this is just a case series. Since the publication, both Dr. Chen, myself, and other colleagues at our institution have had significantly other cases that have been performed. But just an idea that we can stimulate an active nerve root shown here with a Pancoast tumor, placing an actual peripheral nerve stimulator lead, and having some pain relief in patients that could not tolerate opioids, as this example shows. What we've seen is that one of the techniques that's been very helpful to our group has been the ability to target the exiting nerve roots, both in the thoracic, low cervical, and lumbar spine, with both various ultrasound-guided and fluoroscopic, ultrasound-assisted and fluoroscopic confirmed techniques where we can stimulate the actual nerve root. So unlike patients who might have a total knee replacement, where you can target the femoral nerve and or the genicular nerves. In our population, our lesions may be more proximal, such as the psoas tumor shown here. The resections may be more severe, such as a resection of the knee or sarcoma in the femoral space, and such that just a peripheral nerve stimulation of the actual nerve complex itself may not be sufficient. But actually targeting nerve roots has been very beneficial for our patient population. And so these techniques, along with others, were actually published a few months back with a lot of our colleagues, and some of them are actually on this conversation today, just talking about various approaches to the different nerves of the periphery and how these targets may be helpful for different pain syndromes. That leads us to spinal cord stimulation. So obviously there's been a lot of excitement for spinal cord stimulation in the chronic pain population. And it hasn't been as active in the cancer pain population. And there's a couple of reasons for this. Number one, not all of our pain centers are pure neuropathic in relationship. The techniques and devices prior to 2015. Number two, probably were not all MRI compatible. So placing a device precluded a patient from getting an MRI. And I'll explain to you why that might be important in a few slides. And so when you look at the reviews, this review in Cochrane review in 2013, and then actually replicated again in 2017, really did not add any value to the already 2013 literature, really only has 4 trials, all of which are case series. So there's no randomized controlled trial for stimulation in oncology, really just larger case series of what exists with some of our older technologies. So this is a long time ago. So clearly this is the early time where they had leads that were placed with older paresthesia-based systems. You have some patients that seem to benefit in this particular patients, cancer patients, and more post-herpetic neuralgia patients in this population. But again, we have another series. We're using external source of energy for internally placed wires. But there's some evidence in sarcoma and carcinoma patients showing some pain relief in this population. And so a large number of patients had significant relief, partial relief, and the majority of patients, and the sarcoma patients really had a number of patients that seem to have benefited with subjective pain relief in 45 out of 52 patients with their devices. Perhaps more akin to our devices that we use today are the Yakovlev trials, really for both post-thoracotomy and then for post-laminectomy pain related to surgical resections. And they have these, again, case series using larger pulse widths, sensory stimulation, and you have some improvement in both of their trials compared to placebo, but their numbers are low. 14 patients and then 15 patients. That was the 14 patients was for post-thoracotomy, 15 patients for post-laminectomy-related tumors. And again, these are treatment-related pain. So this is not necessarily an active disease, but really a surgical resection that may have led to either incisional pain and or resection-related pain. But the idea of using stimulation is a reasonable one in these patient populations. So what you have now in the literature prior to the MRI conditional systems is a significant number of case reports. So someone treating a T5 meningioma, someone treating a mesothelioma patient. So you have cases in the literature suggesting that stimulation is a viable option. This is from our colleagues in MD Anderson, really just talking about the use of stimulation for chemotherapy-induced peripheral neuropathy. Again, these are paresthesia-based systems using either 80 hertz or motor stimulation at 22 hertz. And you're seeing some evidence of improvement in pain. And this is, again, a group from our group MD Anderson's group, really describing the same idea of phantom limb pain and stimulation in 4 patients having subjective pain relief. And then our group really targeting, using MRI conditional systems, we're targeting a pain related to radiation neuritis, so injuries that are chronic in nature to a nerve. So the conversation really becomes, when do we use spinal cord stimulation versus something similar in its approach, which would be intrathecal drug delivery. Our gestalt is that when patients tend to have a pain syndrome, hopefully neuropathic in nature, that tends to be not evolving or not changing, then they have a possibility of consideration of neuromodulation systems. You really need to think about where you're going to stimulate and make sure that the connection, the central nervous system to the peripheral nervous system, is intact. So the stimulation can potentially have an effect. There's definitely data in the mechanisms of action where stimulating one part of the system may lead to changes all across the system. So you may not necessarily need to have a spinal cord stimulator implanted just to handle a pain that's in the periphery. It may be that you can put a peripheral nerve stimulator or even transcutaneous electrical nerve stimulation, pretty much as long as the dorsal root ganglia is intact, so that signals can penetrate and these signals can go to the central nervous system and reverse some of the plasticity that may already be occurring. And the advances now have been pretty significant. And so the application of these are coming into oncology. First of all, we have much higher frequency stimulation available to our patients now. So before we were talking about either doing 20 hertz stimulation or really more commonly 60 or 80 hertz stimulation, really sensory stimulation of the dorsal columns. But now we have devices that can be 1,000, 10,000 kilohertz, and this may have a different effect and a different pain relieving effect as a result. And you really want to think about interrupting the signaling pathway in multiple locations. So you might be able to place a dorsal root ganglion stimulation. You might be able to get clever with your peripheral nerve stimulators and activating different areas of a somatotopically similarly innervated nerve pathway, similar to what an acupuncturist does. So you may consider targeting the medial nerve for anginal related pain because of the proximity of these second order neurons to each other in the brainstem. So some of these ideas can really open up new horizons for stimulation. There are some concerns with all of these devices. They're electrical devices of both pumps and stimulators can be affected not only by the ionizing radiation, but also by the electromagnetic interference by the linear accelerator that's required to deliver the radiation. So there are some recommended limits, and really most of the radiation oncologists will be aware of how to contour a field around a system to prevent its electrical problems. We've had one communication error with an intrathecal pump with proton radiation that I know of so far in our institution. But nonetheless, one decision may be to wait to have radiation completed prior to considering a neuroaxial system, just as a recommendation. And maybe to think about where your pockets may be and where your devices may be away from a location of a tumor, so that the chance of radiation having your device in the radiation field is minimized. Obviously, we always feel that the oncologic patients have a more infectious risk, but this is data from MD Anderson really showing that the infectious risk with both intrathecal drug delivery and spinal cord stimulators was not significant. It's always in the range of 1 to 3% in their data sets, and I believe our data set's similar, although we haven't published our work. Again, we do have some risk, but it may not be necessarily that much greater than the non-oncologic population. Obviously, there's more precautions to take, both for infections, and probably the more important discussion is really when to choose a spinal cord stimulator and which device to choose. Not all of them are equivalent in terms of their MRI conditionality. and ease of receiving an MRI. And so it's not just that MRI device is conditional, but you need to know what conditions those are. Perhaps work with your radiologist, so we do at our institution, to identify which devices will be the easiest to achieve an MRI at a given time. This is obviously concerning for active disease, especially at patients who are at risk of having compressive syndromes of the spinal cord, where an immediate MRI would be needed. So some of the discussions of using a device is critical with our radiologists to make sure they're prepared to have an MRI if needed for the different devices that are available for this application. So, we took about, are there any variables that might identify us in determining which patients may need a MRI conditional system versus not an MRI conditional system, or an MRI conditional system that is easier to get an MRI in an immediate fashion. And so we looked at the radiology literature and looked at how MRI is becoming more commonplace in oncology. What's even more interesting is that MRI in some instances is replacing CT guidance or CT scans for surveillance and screening. And this is probably most relevant in prostate cancer. So for patients who are at 50 years of age or more, traditionally you're having a biopsy under ultrasound guidance and monitoring your PSA, your prostate-specific antigen level in your blood, as your general classification of monitoring and screening for for prostate cancer. But it seems like more recently, and this is still controversial in the literature, but MRI prostate is becoming established in surveillance for men after age 50 as part of the protocol. So if you think about it, if you're a male and you have a lifetime prevalence of a disease that's 11% in your group, and you're considering have a stimulator placed, you may want to consider having a MRI conditional system already placed, as MRIs are becoming more commonplace to screen for prostate cancer. So our group at Weill Cornell and Memorial Sloan Kettering really debunked through the literature and decided, at this current state, where is the use of MRI being more utilized? And so you can screen for patients who might need an MRI conditional system. What we see is that there's not a role for MRI compared to CT scan and PET scan currently for lung cancer. However, for breast cancer, there is some instances where MRI is needed for these populations for screening and surveillance. Definitely for screening if patients have a BRCA mutation or have a relative with BRCA mutation or have other risk factors for breast cancer beyond that leads to a greater lifetime risk, some various syndromes. So MRI is becoming more common in breast. Definitely, we talked about prostate. And there's some discussion of MRI becoming a surveillance screen for colon cancer. There are some cancers where MRI has been used for surveillance, but not necessarily for screening at this time. So these, obviously, if someone does not have active disease, we feel that MRI may not be indicated for oncology very often, except for prostate, breast, and maybe colon cancer. But for surveillance, so once someone has a disease diagnosed, MRI is much more commonly used for surveillance. So even if you're no evidence of disease after 10 years, if there's any chance of surveillance of your patient in terms of oncology, conditionality of your MRIs may still be important. And obviously, these devices are changing over time. Just a quick talk about future trends. We talked about before about stimulation, increasing blood flow. This is a clever group, and perhaps Manuel may even know this group in Spain. Early work and then some later work on using cervical spinal cord stimulators to increase cerebral blood flow to help a hypoxic tumor, such as glioblastoma, become less hypoxic and therefore more radiosensitive to radiation. And what you see is that there's a little bit more control of the disease in this population. Obviously, glioblastoma, usually the diagnosis until recently, really was a disease that really patients probably had less than 1 year of survival. But you can see that some of the patients in this group and some of the other patients, in 26 patients, had seemed to have both increased cerebral blood flow And the data does show that their patients tended to live a little bit longer than the average would have been. So some clever ways of using stimulation in oncology and in this population. So with this, I wanted to answer any questions, also any conclusions. Really, I think stimulation, as these devices become a little less expensive, may become more available to our colleagues around the world. And really, you'll have to develop a plan of when to use a stimulator versus intrathecal drug delivery. And some of this may be due to whether you believe chemical modulation may be more advantageous for progressing disease. And clearly I can't moderate myself, so I'll figure out if any of you have any questions. I'll see if there's anything in the chat line that I can help answer.
It was a very great lecture, dear Amit. It was very, very, very great and very instructive lecture. And thank you for your lecture and for your moderator also. Or both. And I have one question about TENS. About TENS, and you use it in your practice, or do you give TENS for example, for all your patients, for starting, for example, protocols, or you start directly by PNS, peripheral nerve stimulation?
No, we use TENS quite frequently. Before, we used to place a device and actually have patients try different settings in our clinic. I probably did that much more regularly for the first 10 years. Now we have kind of like these devices that attach to the iPhone, and it's very simple.
Yeah.
So we've kind of transitioned to, those kind of things. So there's some devices that are much easier to obtain that become a little bit, quote, smarter. And so we still advise our patients to try it. They can come to our clinic, use some of the old, or we have them more likely get their device, whatever device their insurance will pay for, or whatever device they buy from, I guess I can say the word Amazon on here, and then they come back with their device and we teach them how to use it. The key is the education of it. The hardest thing is that patients, and like my dad uses TENS units, and it really is, it's something that has to be used every day, which makes it very cumbersome. And so people have to really either believe in it or put those pads on every morning. So easing that and educating is probably the most beneficial way of making TENS successful. And that's what we found was not very successful when a physical therapist used to do this, and they used to take a device at home and then no one taught them where to put the leads and those kind of things. There's some clever things you can do with TENS units. You can put them in acupoints. So if you know your acupressure points or your acupuncture points, you can think of things a little bit differently. But you also have to have a patient that will likely use the device, so they're already motivated to use it. Otherwise, you're looking at those implanted devices, pumps, other interventions.
Yes, thank you.
Yeah, Dr. Galati, a great talk. I have a question. Are you aware of any nerve stimulators, in particular peripheral nerve stimulators for the deep plexus, for example, celiac plexus, or others, and superior hypogastric, etc.? I think all the peripheral nerve stimulators we have, the indications are just the peripheral superficial nerves. Any news, any update in the field?
So indication-wise, it'll be difficult unless you can claim a named nerve, especially below the neck, for the devices that are available. That doesn't mean that people haven't tried putting leads in the paravertebral space, try to capture the celiac plexus. I think Dr. Chen and myself, we've done targeted the nerve roots as they're exiting. So T7, T8, as opposed to the sympathetic chain or the greater splachnic nerves. So we find that to be a little bit easier. From a technical standpoint, I think there would be some novel ideas coming and placing some of the devices in those locations. It's just that while we have those novel ideas, you have to beat a technique that has pretty good efficacy already. So Dr. Bhatnagar, and all the physicians, Dr. Porras, have already described their neurolytic technique, and the data for neurolysis of celiac plexus was pretty good. So really, I think you're looking at stimulation for visceral pain, where you do not necessarily want to ablate the celiac plexus and those kind of things, pancreatitis, chronic. And I think you'll see variations of stimulation that's probably more amenable to peripheral nerve stimulation. But I don't know if we have a device that can specifically target the plexus itself and putting it next to a pulsating aorta and an IVC. Can it be done? I'm sure someone's done a case report, I've done it kind of thing. Is it applicable universally? Probably not there yet.
Maybe for head and neck nerves.
I think your discussion would cover a lot of opportunities for off-label uses.
Correct.
Any other questions? Well, this is a perfect segue for, thank you very much for all of us. I know this has been a long afternoon. We probably should have planned a break or something. But Dr. Kwan here now has really brought up the head and neck cancer. And I'm even for me personally, I'm sure all of us can attest to this. I think this is probably the most difficult group of patients to really treat. A lot of the anatomical variations and destruction of the actual anatomy because of tumors. So I'm excited to hear what you have to say on some of the different techniques you have across the, in Western United States, and just describing some of the ideas for head and neck cancer. So without further ado, thank you very much for being part of this.
Well, thank you. Thank you so much for having me today. I really appreciate the opportunities. And thank you for Amin and Amit for organizing this wonderful talk. I myself, sitting here, have not left and really have learned a lot myself. So I look forward to meeting all of you virtually. I don't know where everyone is located, but we're all over the world. So today, I'm going to give a talk about the interventions for acute and chronic pain in head and neck cancer patients. And I have Erdem, my resident, working together on this project with me at Stanford. This is supposed to be over 100 slides, a talk, so I have to cut down today to make sure that I fit the length of the talk. Let me figure out where to play. All right, and then I listed my email here on the first page, so feel free to send me emails after the talk, and we will communicate further if there's any interest to you and to your practice. So basically, we, as Amit said, that for head and cancer pain patients, they're extremely challenged to manage their pain. But overall speaking, 60-70% of cancer pain can be reasonably controlled just by the oncologists themselves. About 1/3 of them are poorly controlled. And for the head and neck field, as you can see, the prevalence of pain is really, really high, almost 87 to 90% of them. And even following the treatment, of the surgery, still a significant amount of people, 70-80% of them are still having significant amount of pain in head, face, or in the mouth. The very complex and poorly understood nerve innervations of head and neck made this interventional modality extremely challenging in treating pain associated with the head and neck cancers. As you can see from the right side corner, the face of the nerve innervation to the head and the neck and face, they're overlapping with each other. It's very complex, such a small body region as well. So in today's talk, I'm going to review briefly the nerves and ganglions of the head and neck. And then I will put some correlated clinical imaging findings of tumors with head and neck pain. And then I'll review briefly the current pharmacological intervention, mainly two interventions, lidocaine IV lidocaine infusion and the ketamine infusions. Then I will introduce the CT-guided interventions for head and neck pain. It could be applied to other pain conditions as well, but obviously here we'll be focusing on cancer-related pain at our institution. So the first nerve we're going to talk about is obviously everyone knows here is the trigeminal nerve, is the largest cranial nerve, and with the sensory roots in the pons. It's V1, V2, V3 branches here. And then they merge together above the foramen, and at the Merkus cave, they form the Castalian ganglion, and then they, form the synapse in the trigeminal nucleus in the brainstem. As you can see, the foramen ovale at the base of the skull is very big. That's V3 nerves goes through, while the foramen rotundum, which is a much smaller bony hole for V2 nerves to come out from the skull base, and V1 from the supraorbital fissure. So they all merge together at the Merkus cave to form the Ganglion ganglion. As you can see from this MRI images, you can see they're kind of like a small shaped, kind of like a bean-shaped structures here in the middle brain fossa. And the shape of Merkus cave can alter a lot. It depends on individual person, their body size, and etc. So sometimes we're not entirely. They're not entirely consistent from people to people in terms of the size of it, location of it, etc. And then also, this is conventionally how we blocked the Ganglion ganglion through the fluoroscopy guidance, go through the foramen ovale, as you can see, and this is relevant location to the carotid artery. So location of the needle entry point is important. You don't want it to get into aortic arteria punctures when you do this type of block. And there are some pathologies here. As you can see, commonly tumors that affect the trigeminal nerves are the schwannomas. It's right here, as you can see. And then there's also lymphoma. Lymphoma also loves to go to Merkus cave. For example, on the right lower corner, left corner, you can see here the white arrow. This is this lymphoma through the perineural spread from the foramen ovale, and then go into the Merkus cave. And then it's right there. And then also there are melanomas, and then also squamous cell carcinomas. They all love to go in there to the Merkus cave. So that's trigeminal ganglion and Ganglion ganglion. And then the second nerve, second ganglion I would like to present to you is this phenolpalatine ganglion. This is my favorite ganglion of the head, mainly because the complexities of it. As you can see, it's right here. It's behind the bony structure of the nose, very, very closely associated with trigeminal nerve. Is responsible for trigeminal autonomic reflex. And it's within the fossa. It is within fossa. It's a parasympathetic ganglion. It's right here too. As you can see, this is the middle turbinate. It's behind that. It's SPF is right here. So it receives three types of inputs. It receives a sensory. So the sensory is from the V2 nerve. Parasympathetic is from the facial nerve. It's from the facial nerve through it's right here, through the greater petrosal nerve. And a sympathetic components as well from carotid plexus, superior, cervical ganglion, and through the deep petrosal nerve. So these phenolpalatine ganglion is really very, very significantly involved in the innervation of brain vascularization. Therefore, it's involved in migraine, cluster headache, vascular headaches, and then atypical facial pain. In a lot of cases, when I have a tough cases with facial pain from whatever, and if I'm exhausted, everything else, phenolpalatine ganglion will be the next one for me to block and try out. As you can see, this is a blow-up picture. As you can see how complex it is for phenolpalatine ganglion to receive inputs from various nerves, from trigeminal nerve, facial nerve, and also from the superior cervical ganglion. So the tumors right here, you can see, this is a CT images. You can see this foramen rotundans go into the brain, and this is a pterygopalatine fossa, PPF, and where this phenolpalatine ganglion is. And you can see soft tissues, mass, for example, parotid gland tumors, or the musculoskeletal tumors on the face that can with just a mechanical compression and invading into the PPF, etc. And then also you can see this is nasopharyngeal cancers because they basically stay behind the nose. So nasopharyngeal cancers love to go in there and cause a problem. So the third nerve I wanted to introduce is the facial nerve. So the facial nerve is obviously it's a very important nerve for our facial expression and also for our motor functions, as you can see. So facial nerve comes out from the facial canal through the steromastoid foramen and innervates the face, as you can see here. And then this is the facial nerve also, obviously, as we talked about before, has a very close interaction with the phenolpalatine ganglion. The facial nerve itself, it will form and geniculate ganglion. It's a very bony structures right here. And then it causes problem, and then exit the base of skull through the steroid mastoid foramen. This is an important concept, as I will present to you later on for technologies we developed here at Stanford that we're able to target facial nerve for the first time using radiofrequency rhizotomy to treat certain facial conditions such as hemifacial spasm. So there are relevant pathologies. You can see there are the tumors can very easily grow into, for example, this is a malignancies of the paravertebral subcutaneous skin melanoma go into, and then invading into it. And then there's on the right side, there's a geniculate ganglions being invaded by the hemangioma. So the fourth nerve is glossopharyngeal. Glossopharyngeal is the cranial ninth nerve. It comes out from the brain through jugular foramen and then course through a steroid process and then innervate, obviously, the neck and then pharyngeal area and then also the deep ear. And then you can see right here, and then the steroid process, glossopharyngeal nerve right here. And there's a tumor. This is a schwannomas of the glossopharyngeal nerve. Etc. The final nerve I'm going to introduce today is the occipital nerve. Obviously, the occipital nerve, most of us are very familiar with. It comes out from the C2, C3 spinal nerves and form, they're greater, lesser, and third occipital nerve innervating the skull and cranial surface of pinna, and often implicated in a cervical genic headache and migraine. And as you can see right here, there's schwannomas nearby, and then pushing down the tissues, and the occipital nerves got really inflamed. And this is another structures of 3D reconstruction. You can see the C2 nerves, the occipital nerve comes out for C1, C2, etc., and it goes innervating the back of the head. So with that being said, obviously we use a multimodal treatment modality to treat this type of conditions. I'm not going to talk about, due to time limitations, of other opioids and non-opioid adjuvants, etc. But I'll focus more on lidocaine infusion and ketamine infusion, which Erdo and then I work on together, and then it will followed by procedure interventions. So lidocaine infusion is really a sodium channel non-selective blockers. It also, very interesting, has an anti-inflammatory and anti-hypergesic kind of effect. And it's really effective in terms of alleviating some of the mechanical allodynia, hyperalgesia associated with chronic neuropathic pain, including cancer pain. So, and then there's a lack of high quality data still, a lack of ICT assessing efficacy of cancer pain. Nevertheless, some of the studies that can give us some ideas that, either a bolus followed by an hours of infusion, and also infusions, a bolus followed by infusions, in the cancer patients that had a significant amount of pain relief with no serious side effects, etc. So the guidelines are really based on our institutional experience is that we start the lidocaine infusions around 0.5 to 2 mg per kilo per hour, and then it takes about 4 to 8 hours to reach a steady state, and we check its levels every 12 hours so to make sure we don't go into toxicity levels, etc. So I'll just briefly go through this because, running out, I wanted to focus more on interventional part. So, and then the ketamine infusion, we also have reviewed the data here at the Stanford, that in terms of how it works. Everybody knows it's an NMDA antagonist. It could work by reducing its hyperalgesic and chronic, alters the chronic pain plasticity. Could be very helpful for head and neck cancer pain patient. I want to mention further, and then ketamine infusion usually does not have only very minimal respiratory depressions, so it's especially suitable for head and neck patients where we have concerns of respiratory depression. Anyway, so those are some of the studies to look at ICTs for intravenous ketamines for cancer patients, and the data is really not very high quality, but there are some indications that it could be quite helpful. So we reviewed the data last year and this year. We reviewed about 200 records. We have 12 patients that with a trigeminal neuralgia, neuropathy, or atypical face shaping from various reasons, including tumors, where we were able to find out that the patients who have pain limited to the nerve with localized facial pain tend to respond pretty well, while the pain has no dermatome distributions. For example, atypical has the least favorable response to it. So we just submitted this articles for further review. So basically, I will do a bolus, and then followed by basically, typically it's about 10 milligrams per hour of the infusion, and titrate up to 30 to 50 milligrams per hour per patient's response, etc. So anyway, so today, let me focus on my second half of talk on head and neck CT guided block. Those are all the blocks that I do routinely at Stanford. I'd like to share with you. The first block is the V2 block at the foramen rotundum. So, and we all know that traditionally with hot tail technology, to block trigeminal nerve different branch, the needle has to go through the foramen ovale, where actually the V3 goes through it, right? So we'll go through the foramen rotundum, and then we'll go into the Merkus cave, the ganglion. We have to move the needle around for us to ablate V2 or V1 for patients who have a single branch disease. This is really a painful procedure if you've done this, and it's very technical challenging. This is how I typically do it on the furrow in the past, and you see the foramen ovale, and then with that lucency, your needles go through it. With your IF needle, you move around to find the third division, second division, or first division. And then sometimes if it's multi-branch problem, or people who worry about motor weakness or too much of sensory, hypergesia, we inject glycerol, 100% of glycerol. That is helpful as well. We do here on a routine basis. Sometimes we do balloon. Balloon compression. The way that we do balloon compression, which I will demonstrate for you later, we do awake technology, and then we do sequential ablations. In the literature, that the balloon was done most of the time is under GA. So advantage is very widely used, very easy to do. However, if you wanted to get single branch, it's very, very challenging. Okay, so the needle oftentimes has to be there for a long time, and it could cause a problem with leak, infection, bleeding, puncture, etc. And then oftentimes you really don't know where your needle's ideal position is once you're in the Merkus cave. Remember, the Merkus cave, the size, the shape could vary a lot among individual persons. So you really don't know the ideal tip. Too much, you're going to cause CSF leak. Not deep enough, then you're not on the ganglion itself. So the interventions you do, glycerol, balloon compression, IFA, is not going to be as effective. So with this kind of in our mindset, in 2014, I was like, okay, let's see whether we're able to ablate the V2 at the foramen rotundum, at the new location, instead of at the conventional Dr. Hartel's technology. That was actually developed in 1912. Almost over 100 years ago. So we tried this technology out in the skull-based samples, a couple of skulls, and we're able to build up our database from skulls CT, and we're able to find out that there is a possibility to go into foramen rotundum without any problem. So we recruited 27 patients with V2 trigeminal neuralgia alone, and we did the studies. As you can see, the foramen rotundum is clearly visualizable. And then there is a pathway that our needle can go in. So with that, we did the study. As you can see, the needle entry point is very different now. Okay, so conventionally, Dr. Hartel technology is 2 centimeters away from corner in the mouth. However, now we have moved the needle much higher in the cheek. It's subzygomatic, at the base of the nose. Okay, so and that's how our needles go into the foramen rotundum to ablate the branches there. So this way is much specific and clear, etc. And our study showed that the foramen rotundum approach is possible to be done. And then we published this article. Later on, we advanced this, improved this technology with flat panel dyno CTs, with even more precision, easier to do, with much less procedure time for our patient. So we published this article in 2014 in Pain Medicines. And then we also developed this new technologies doing awake CT-guided compression, balloon compression of Ganglion. As you can see, clearly the needle goes through the femoral tendon, and then with the catheter's extension just right into the mucous cave, and we inject contrast, and we can see this piriform shape of the balloon, which is the best indicators of a successful block. Under CT is very, very easier for us to see. However, on the furrow is difficult. And then also we do this procedure with patient awake so that we sequentially increase the pressures inside the balloon. And then we test lifetime of their paresthesia and the motor weakness. This way, patient has the least motor weakness following the procedure, and they have sufficient paresthesia to have sustained pain relief. And as you can see, piriform shape of the balloon group really is important, as this paper indicates that if it's a piriform shape, you almost have close to 100% relief. While if you have an oval shape, you only have about 50%, and they're not sustainable. With furrow, it's difficult for you to know where you are. So we're in submission of this article of our balloon paper. And then our program also routinely treat patients who has a glossopharyngeal nerve problem from cancers, from other conditions. As you can see, conventionally it was done on fluoroscopic guided technique. Sometimes if patient is thin, you can also use ultrasound, but not always you can see the structures. So when we utilize in CTs, it becomes a much easy things to do. You can see the startup process, and then use a needle, just hit the bone, and then you walk posteriorly about 2 to 3 centimeters, and then using electrostimulation, you're able to see the nerves, and you will be able to localize the glossopharyngeal nerve fairly easily. We published this paper in 2018. And then for the last 2 years, we've been developing this new technology is for people who have facial nerve problem, either from tumors, from mass, from neuropathies, from viral infections, or failed the conventional therapy, for example, microvascular decompression, or from Botox. So the Botox injection and MVD are the only two available options for people who have facial nerve neuropathy. In particular, hemifacial spasms. Hemifacial spasm patient, if you see them one time, you will never forget about them. Their dignities, and their appearance, it just completely altered their life. And then in the past, if you cannot find a blood vessel compression on the nerve, then you're screwed. You don't know what to do because MVD will not be offered. They have to get a Botox injection every 3 months or so and make their face really stiff and stone. And over time with Botox injection, they loses efficacy as well. And it's expensive. So with that kind of a background in our mindset, we started to develop technologies at our institution, and we're able to find the styromastoid foramen, and where we can see that the facial nerves just exiting the cranial nerve, and then we put our needles there to do a sequential, as you can see right here, and we do sequential a block of, again, it's awake and intermittent ablation. As you can see that the patient, our data, we recruited 53 patients so far, and we can finish the studies this year. And our patients' long-term success at this time, Kaplan-Meier's curve, is with 90% of symptom relief at 18 months of follow-up. I'm really happy about the results. And most of the paralysis from facial nerve ablation is minimal and mild to moderate, and most of them recover after 6 months. And our paper is right now is in print and accepted by Journal of Neurosurgery. And then for the C1, C2 block, for the occipital nerve problem, for the occipital headache, and for innervation, etc., the conventional furrow guided C1, C2 block is possible. It's not impossible. It could be done. And also, in fact, we do that. I do that as well. And then sometimes even ultrasound guided, but not always successful. For complex patients or people who have failed, then we have developed the CT-guided C1, C2 block. It's very clear. As you can see, this patient, on the left side, the C1, C2 joint space is very clean. However, on the right side, the contour, the joint space is being altered. No surprising, this patient is presenting with a horrible daily cervicogenic headache. And once we got into that space, we were able to completely eliminate the pain for this patient. So with that, I will conclude my talk today. This is a reference, and this is our new hospital, by the way. Our new hospital just opened up this year before COVID, and I was lucky to have a hybrid room where I work with my colleagues for various pain procedures. Thank you so much. That concludes my talk today.
That was wonderful. That was really good discussion on the anatomy, and then obviously you're really optimizing your CT guidance on your technique. Do you have any advice for perhaps our colleagues? How can we? I guess how do you work with radiology? I assume to get CT guided time, or how would you say recommend some of our other colleagues get the opportunity to do this under CT guidance with radiology, etc.?
Yes, that's a great question. You know, I can't. I'm not a certified radiologist, and I don't want to. I know the anatomy is very well myself, but I still rely on my interventional radiologist to be my colleague, to be my partner, to do these procedures. So every time when I do this, I will have a radiologist kind of come in for the imaging part, scanning part, and also the planning part, and then they're done. And I do have IR fellows who work with me all the time, together with my pain fellows and resident, etc. The learning curve is very short. I mean, because even though it sounds very complex, but I think once you review the images with the radiologist for about 3 to 5 times, you get a sense of it, where to go, and etc. But I obviously I don't want to take over, so I let my radiologist colleagues to continue working together with me. I think that's better, and they start to refer their patients to us as well. So which turns out to be win-win situations. And I think I wouldn't recommend our pain colleagues here to learn how to scan yourself. I would say just work with your colleagues from your radiology department. And for them to take on the imaging part, and then you just work on the patient selections, and then the intervention recommendations, and the procedure itself, and then follow up. I think that will work.
Any other questions?
Yes. Dr. Kian, I'm very happy to have you today. Thank you very much for your great presentation, great lecture. And I have some question about infusion lidocaine and infusion ketamine. How do you do, for example, for your patient if you start with this infusion, or this is co-adjuvant treatment with interventional pain procedures?
Yes. So those infusions are extremely easy to do, and then I think I really in a lot of times I am promoting this to my international colleagues, because I also do acute pain service at Stanford. I do pain calls every 1 week per every month or so. So I'm very familiar with this literature and with this type of infusion. So lidocaine infusion, for example, easier for everybody to remember is just use, obviously you have to check the liver function, make sure the liver is fine. They're not pregnant, and they don't have underlying significant cardiac issues. They don't have seizure history. That's all. And you starting the dose at 1 milligram per kilo per hour. That's it. Sometimes you should using a bolus before the infusion, but you can skip that. 1 milligram per kilo per hour to start, and then you check the serum levels, every 12 hours or so, so that they don't go up 5 microgram per cc. You can talk to your the lab in your hospital. It's not a secret. You can check the level fairly easily, and it's really helpful. And for a lot of patients, for head and neck patient, cancer patient, they're neuropathic, and this is perfect for them. For lidocaine. And then for the ketamine, we also do fairly often. Anyone who obviously has bipolar, mania, or intracranial hypertension, closed angle glaucoma, we don't want it to start on, or cardiomyopathy for CHF, for example. EF is less than 30%, we don't want to use them. But everybody else, almost everybody else, you can give it because it doesn't take away your breathing. It's fairly tolerable. So I typically use either dose by kilogram per hour, or I just start with 10 milligrams for my cancer patients. I start with 10 milligrams per hour. That's it, and see how they tolerate over the next 12 to 24 hours, and then I slowly titrate up. We don't need to check their blood levels. So the ketamine, lidocaine, we have to check their levels, but ketamine we don't. So it's even more practical to do so. But in terms of its literature for head and neck cancer patients, I think we don't have good evidence. We really don't. So we're working on that. We did a retrospective study this year. It does show that for people who have trigeminal neuralgia or neuropathy, as long as the pain is still following the dermatome distribution, it works. Either it's short-term or long-term. But for people who have pain beyond that nerve distribution, for example, like atypical facial pain, we don't see very good results. But for the head and neck cancer pain patients, usually their pain is along the nerve distribution. So we are working on the next step of reviewing in our institutional review is that to look at head and neck patient with no nerve neuropathy or neuropathic pain and see whether ketamine infusion will do anything for them.
Okay. Thank you very much.
Oh, you're welcome.
Well,
one follow-up question based on a chat. Do you use any of the oral ketamine or nasal ketamine formulations in your practice, or are you strictly staying with intravenous ketamine? And a corollary is, what's your outpatient duration?
Very good questions. Yes, I do use both of them. So in the past, we use mainly oral ketamine. Oral ketamine, however, has a very poor bioavailability, 30 milligrams twice a day or so. Very bad bioavailability, so people don't think it's very effective. So 2 years ago, FDA approved the intranasal ketamine spray for major depression therapy. So I think that kind of gave us a relief. Okay, it's safe to give, right? At least. So and then that prompted our use of intranasal ketamine infusion for intranasal ketamine spray for our chronic pain patients. So right now we're getting it from compounding pharmacies, and I give, if they respond well to inpatient intravenous infusion, IV infusion, I will give them options of intranasal spray. Each time 15 to 30 milligrams of spray as needed. And most of the people really love it, that, this could be something as maintenance therapy. And it's very easy too, and it's cheap. And I think 1 month's of supply is about $15 to $20 for our patients here. So it's really affordable. So the answer is yes, we do both, but now I'm leaning more geared towards the intranasal ketamine spray.
Excellent. I guess we have two more questions, and perhaps we'll sign off at that. I know it's getting late for everybody. One question is, what's your opinion for using ultrasound-guided maxillary nerve block at the pterygopalatine fossa for trigeminal neuralgia, and would you pulse radiofrequency this? And I guess that's one of the questions I had. Do you have any experience with pulse radiofrequency in addition to RF thermal ablation?
Yes, very good question. So yes, I have done multiple, the ultrasound-guided V2 block at the pterygopalatine fossa, especially in our younger patient, pediatric patients, we've done that. And people who have very thin, body habitus, we've done that. I personally don't do pulse because I don't think it works. I'm sorry. I think it's just a one-time PNS treatment. I could be biased. I think we have a lot of expert here for peripheral nerve stimulators. I think pulse radiofrequency in America is, in many ways, is no longer reimbursable anyway. So you have to fight with the insurance companies all the time. And then also in your practice, you really see it's inferior clinical efficacies comparing to other therapies. Of course, we all worry about the ablation cause neuropathies and anesthesia dolorosa and etc. That is a problem. So therefore, I vote for peripheral nerve stimulators. And I think that when we don't have a peripheral nerve stimulator options, we have to kind of stick with the nerve ablation options. But there's various of options. There are, there are kind of milder, for example, glycerin, which is milder. In balloon compression, at least for trigeminal neuralgia, patient is less, less severe, and then sometimes if you worry about, you can, like me, for the facial nerve, we worry about paralysis. That's your number one concern. So I do sequential ablation. Once my needle is at the styromastoid foramen, I heat up the nerve at 60 degrees Celsius. Then I gradually go up to 65 to 70. Each time I ask my patient to, kind of puff up their cheeks. As long as they can do it, then I'll continue to ablate. Just about the time they cannot do that, then I stop. And I think we probably partially ablated the facial nerve. That's it. And then that's enough to stop the facial nerve to spark. The hemifacial spasm is gone. 99% of them is gone. It's good enough. But then you got this partial paralysis. Because it's partial, it recovers. 3 to 6 months later, most of them fully recovered. However, the benefit of getting rid of spasm is still maintained. So very, very happy about that.
That's great. I know, just to let our colleagues know, there are some neurosurgical techniques such as nucleus tractus chordotomies that some people around the world do for this problem. Our radiation oncology colleague can ablate it with the radiation gamma knife and those kind of things. So different ways of managing. Also, this answer to the final question kind of goes along with what you just stated, which was peripheral nerve stimulation. Any ideas of relieving trigeminal neuralgia pain? I sent a few patients for using the older systems to stimulate supraorbital and infraorbital infratrochlear nerves, some of the older devices for migraines and those kind of head and neck cancer. But anything that you've done with peripheral nerve stimulation for trigeminal neuralgia specifically?
We have a surgeon here that does the trigeminal and ganglion stimulators. I would be honest with you, I don't think the results is very good. There's lots of complication as well. I would not touch it at this time, but I look forward to peripheral nerve stimulators. And I really think the hope for head neck patient, if you want to give them another options, especially if it's non-cancer patients, then you want to have a viable, sustainable option. And I really think that peripheral nerve stimulator is next things to go for our pain field as a whole.
Excellent. I tend to agree. Although we don't have much experience with stimulation of trigeminal nerve, I know the devices came out for Ballotine ganglion, and those kind of never taken off. Any other questions from our colleagues here?
The last question, please, Dr. Xiang. I want just to ask about hallucination of ketamine. Is there any treatment you add to ketamine, or you just give ketamine in infusion?
Oh yeah, so definitely that's one of the dreadful side effects of a psychoactive kind of dissociative side effects from ketamine. That's why you start low. You start at 10 milligrams per hour. People usually do very well, and then you titrate up to their pain relief and also their side effects, so that and you counter with benzodiazepines if they do develop psychoactive kind of side effects. And most of the time, it's really well tolerated for our cancer patient. And then they also elevate their mood. I think it's really win-win. So some of the hospice here in the Bay Area, in Silicon Valley, we noticed that from this year have started to offer in-home ketamine infusions for some of our patients with PCAs. They used to not to do it, but I think there are just enough patients who responded well to the ketamine infusion, end-stage cancer patient, hospice patient. They are happier, they eat more, they know it's safe, and they started to offer that. And I was just so happy to hear that. Some of the hospices, I left my phone for them, so they can call me for my patients if they run into problem.
Okay, thank you. Thank you so much.
You're welcome.
We have, I guess, 2 more quick questions. A simplex needle for injecting the maxillary nerve as opposed to a spinal needle. I'm assuming the simplex needle is a blunt needle, but I'm not even sure what that is.
Yeah, so simplex needle is just the simplex needle is bigger, and spinal needle is smaller. And then obviously on the ultrasound, you can see better when the needle is bigger. Sure. I just use 22. I always, for the maxillary nerve on the ultrasound, I always use simplex needle because I can stimulate. Landmark itself is not enough. Remember in the pterygopalatine fossa, you also have a sphenopalatine ganglion there. So you don't want to take that out. So you wanted to stimulate and make sure you only get the V2 maxillary nerve.
All right. And then the last question, I think, is your opinion on intranasal insertion of lidocaine blebs for sphenopalatine block. Not rely on the user to tell me lidocaine blebs specifically means.
Yeah.
Pulses.
It's probably the nasal swab with the lidocaine. And it's a very, very convenient, very popular therapies for in the migraine field, in the headache field. People do that to treat, migraine headache and classic headache. I would like to share with my colleagues here that I've been working together with the ENT colleagues at Stanford. We're doing an endoscopic guided intranasal block of sphenopalatine ganglionic nerve blocks at the sphenopalatine foramen inside the nose. And we have found some really good relief for the atypical facial pain patient. And we have been using off-label Exparel because we found out that Exparel is the liposome form of bupivacaine. So it can last much longer, like 36 to 48 hours of lasting benefit. The conventional bupivacaine only lasts maybe anywhere from 8 to 12 hours, but the liposome form of Exparel can last longer. We've been injecting Exparel intranasally around this sphenopalatine foramen, and we've seen really good data. So the regular lidocaine bupivacaine give you about maybe 2 to 3 days of migraine headache relief. The Exparel can give us up to 2 weeks of relief because of it's longer, but it's so preliminary. I don't want it to mislead anyone here, but I think it could be optioned. That you don't need to poke your nose every day in the future for the migraine patients.
That's wonderful insight. Again, thank you very much, Dr. Kwan, for being part of this. And obviously, all of our colleagues are still with us. Thank you from the bottom of our hearts for a really good discussion. I think the last 3 hours on end cancer pain. I actually learned quite a bit from every one of you guys. I don't know if you have any closing thoughts, but thank you once again for everyone who joined us.
Yes, I want to thank everyone for faculty. I want to thank you very, very, very much for your contribution, your support, and your presence. And I hope to see you in not a virtual meeting, but see you again in a direct meeting soon. Thank you very much for all the faculty and the attendee, and thank you, Dr. Amitabh Kulati for moderate and for your intervention. But you are the instigator of this meeting. You have all prepared this meeting. I want to thank you very, very, very much, and hope to see you again. Hope to see you in Morocco next year for the second WAPMO meeting, North Africa, and hope to collaborate with all of you for developing this file in Africa and in Morocco especially. Thank you very much. Thank you for all the attendees. It was a great, great meeting, and I will be happy to see you again. Thank you. Thank you very much.
Thank you very much.
Thank you. Thank you. We should be in touch.
Keep in touch.
Okay. Bye-bye.